Okay, all set now.
Thank you very much. Good morning. It's Thursday, March 25th. Welcome to the morning session of the Joint Standing Committee on Health and Human Services. We are assembled around our virtual horseshoe this morning and are live streamed on the HHS channel found on the Maine State Legislature's YouTube channel, where you can find the replay of our proceedings should you miss us live. This morning, we'll hold public hearings on the following bills in this order: LD 595, 512, and 674. For those testifying, please ensure the name you're using on the Zoom webinar matches the one you used when signing up to testify. And we would ask that in order to help our clerk manage the attendee list, you exit the webinar once you've finished your testimony and answered any questions from the committee, and watch the rest of the hearing live on YouTube. We'll be taking testimony in the following order: the sponsor, any co-sponsors or other legislators, those providing testimony in favor of the bill, then those opposing the bill, and then finally, those neither for nor against the bill with additional information for the committee. We do run a 3-minute clock on testimony, and you will receive a prompt when you have 30 seconds left, asking you to kindly bring your testimony to a close. Public hearings are just that, for the public. The process of hearing their testimony certainly engenders and encourages probing questions, and the committee is asked to use the raise hand function in order to ask those bill-related questions. We will do a quick round of introductions, starting with Representative Zager.
Thank you, Madam Chair. Good morning, everyone. My name is Sam Zager. I'm honored to represent District 41 in Portland.
Representative Lemelin.
Good morning, everyone. I'm Michael Lemlin, representing District 88, Chelsea, Jefferson, Whitefield, and half Nobleboro.
Representative Stover.
Good morning. My name is Holly Stover. I represent House District 89, including the towns of Boothbay Harbor, Southport, Edgecombe, West Port Island, and part of South Bristol.
Representative Griffin.
Good morning. My name is Abigail Griffin. I represent House District 102, which is Glumburn, Levant, and Kenduskeag.
Representative Craven is in another committee and will join us shortly. Representative Madigan.
Good morning. I'm Colleen Madigan. I represent House District 110, which is part of Waterville and part of Oakland.
And I am not seeing Representative Perry. Representative Javner.
Good morning. I'm Representative Kathy Javner, and I represent House District 141, which is located in Penobscot and Washington counties.
Senator Moore.
Good morning. I'm Marianne Moore, and I represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, and Sullivan in Hancock County as well.
Senator Claxton.
Good morning. My name is Ned Claxton. I represent Senate District 20, which is Auburn, Minot, Mechanic Falls, Poland, and New Gloucester.
And I am Representative Michelle Meyer, serving Southern Maine's House District 2, which is all of Elliott and parts of Kittery and South Berwick. With us today is our analyst, Erin Dooling.
Good morning. My name is Erin Dooling. I'm one of the legislative analysts supporting the Health and Human Services Committee.
And our clerk.
Good morning. My name is Carrie Withy, and I'm the clerk for the Health and Human Services Committee.
So with that, I will open the public hearing on LD 595 and welcome Senator Marianne Moore to introduce the testimony of the sponsor, Senator Trey Stewart. Welcome.
Good morning. Thank you, Madam Chair. Yes, Senator Stewart is out of town, and so he asked me to read his testimony this morning. He apologizes for not being here at this important presentation of LD 595. So I will read his testimony for you. Senator Claxton, Representative Meyer, and members of the Health and Human Services Committee, Senator Trey Stewart, and he has the distinction of representing 51 communities in Aroostook and Penobscot counties. He is here today I'm here today to present for him LD 595, which is a resolve to ensure that access to oral and facial ambulatory surgical centers in Maine remains viable. This bill came to him by way of a local doctor in Presque Isle, Dr. Hank Ford, who runs the Northern Maine Oral and Facial Surgery Center. This center is the only ambulatory surgical center in the state, and they serve patients across all of Maine, including as far south as York County. We are fortunate today to have Dr. Ford join us and participate in this hearing this morning, and I look forward to hearing his testimony as well. One of, if not the largest insurance provider of patients of NMOFSC is Maine Care, which is the Northern Maine, that acronym stands for Northern Maine Oral and Facial Surgery Center. And one of the largest providers is Maine Care, which is not all that surprising, given that Maine Care insures over 20% of the state. As you know, these are individuals who are low income and particularly in need of assistance. And yet the system that is designed to protect them may soon preclude them from being able to access critical services at all. Previously, when Dr. Ford's office began accepting Maine Care patients, they contacted the state to determine what they should bill under the Maine Care's coding system. They were informed that 41899 was the code to use, which was apparently exclusive to their office, given that it's the only ambulatory surgical center in the state. Since then, the rate has not increased. Now, years later, the cost of treating those same patients has continued to go up as the cost of doing business has gone up, and the governmental regulations imposed on these healthcare facilities has increased. Dr. Ford's office has now reached the critical point at which it is no longer feasible to continue to operate and serve these individuals, which is why he contacted myself and Representative White last year about putting in this legislation on his behalf. This bill is simple, yet will have a very positive impact for our state. It increases the rate that ASCs can bill under to $1,250 for freestanding ambulatory surgical centers performing procedures on the dental, oh boy, I'm good with it, dental velar. I'm sure Dr. Ford can correct me on that structure. Dr. Ford and his staff worked to come up with this amount based on the actual cost of providing these services to patients. To be clear, this amount will not allow Dr. Ford's office to get rich, but rather to break even and continue providing these critical services to the most vulnerable population in our state. If we do nothing on this issue, Dr. Ford will no longer be able to provide these services, and Maine citizens on Maine Care will no longer be able to access an ambulatory surgical center for facial and dental procedures. Given that Dr. Ford's facility is the only one in the state that actually bills under this code, the fiscal impact of this change is limited, and we look forward to making the pitch to fund this initiative off of the special appropriations table later this year with the support of this committee in the form of an affirmative vote. We appreciate Dr. Ford's willingness to engage with us this morning and want to ensure that we will have time for his testimony on his tight time frame in between surgeries. So I will end my remarks here. I appreciate the committee's time and attention to this important issue and would be happy to answer any questions you may have at this time. And Senator Stewart said that he would be available for the work session at that time. So thank you for allowing me to present his testimony.
Thank you, Senator Moore. I see that Dr. Ford is in the queue, and so I would welcome him to come forward, unmute yourself, and provide your testimony.
Are you able to hear me?
We are, Doctor.
Great. Good morning, everyone. Senator Claxton, Representative Meyer, and distinguished members of the Health and Human Services Committee. My name is Hank Ford. I am a board-certified oral and maxillofacial surgeon, and I live and have practiced in Presque Isle for over 20 years. I am the director of the Northern Maine Oral and Facial Surgery. Our practice includes a Medicare, Medicaid certified ambulatory surgical center, which is the only such facility for my specialty in the entire state of Maine. I am testifying today in support of LD 595. Our practice covers all manners of oral surgery services, from bone grafts to cleft lip and palate work, impacted wisdom teeth, facial traumas, reconstructions, among many other procedures. Our patients come from all over Maine. We have patients who regularly make the trip from Bangor and below because they do not have access to affordable oral and maxillofacial surgical treatment in that area. Indeed, some of our patients come as far away as Kennebunk. The challenge of providing quality medical services in Aroostook County is unique. Our county, like many of the collar counties in Maine, is medically underserved. But in many respects, all of Maine is underserved, especially in regards to oral and maxillofacial surgery services. We are also unique in that we have an ambulatory surgical center, or an ASC, as part of our practice. It is an incredible resource. Many dental procedures, such as facial fractures and traumas, difficult dental extractions, and oral pathology, can be done safely as an outpatient procedure, and the patient can be discharged the same day. In addition, these procedures can be done in our ASC at a fraction of the cost that would otherwise be charged in a hospital. Many of these patients pay for these procedures out of pocket, and it can be 10 to 20 times more expensive in a hospital setting. For people in the county who oftentimes have to travel to Bangor to receive medical assistance, having this resource is critical to their recovery. Quite a few of the patients we treat on a daily basis have compromised medical history. The ASC allows us to treat these patients here in the surgery center. Northern Maine Oral and Facial Surgery Ambulatory Surgical Center provides a safe anesthetic management option for patients of all ages requiring medical and dental procedures. Our surgical team maintains advanced cardiac and pediatric life support certifications. At NMOFS, our staff is at your side from the preoperative through the recovery period. The Medicare and Medicaid and AAAHC certifications allow us to provide surgical care for our patients in a convenient and private setting. This also allows a high degree of cost control, privacy, and scheduling convenience. Keep in mind that I do keep a full schedule here at the surgery center and also go to the hospital here, where I am on staff and operate several times a month. Extremely medically compromised patients, as well as surgery such as reconstructions that require inpatient stay, are always done at our local hospital. The challenges of maintaining an ASC at our level are quite significant. Yearly costs, recertifications, and building upgrades required a large financial impact on the surgery center. Our highly skilled team also requires yearly certifications to maintain the required trainings. All of this comes at a cost as well. Our goal is to care for patients with a more convenient alternative than the hospital-based outpatient procedures that requires equipping the center with the latest technical equipment. The future of dental care in an underserved community is of great concern. On average, only about 200 to 300 oral and maxillofacial surgeons graduate each year. Recruitment to maintain or add services is already an extreme challenge in a rural area such as ours. NMOFS Ambulatory Surgical Center is the only freestanding ambulatory surgical center owned by an oral surgeon in New England, and quite possibly the only one on the East Coast. We get calls daily from dentists and providers from all over the state with questions and concerns and a need to get their patients to an oral surgery quickly. An increase in the facility fee would allow this practice to see more main care patients in a timely manner without compromising the quality of care or causing the financial hardship to the surgery center. Without this surgery center, I believe you would see our emergency rooms getting flooded with dental problems, requiring patients to be admitted to the hospital as an inpatient or being transported to Bangor or Portland for their oral surgical needs. I thank you in advance for the opportunity to testify. I'd be happy to answer any questions, and I will attend the work session. Thank you.
Thank you. Questions from the committee for Dr. Ford? Yes, Senator Claxton.
Good morning, Dr. Ford. Welcome. Thank
Good
you for your
morning.
testimony. Can you give me some idea when that code was developed for you and what the compensation was at the time?
The code was established for us, I believe, in 2014. And the exact amount, hold on 1 second so I'm accurate for you. It's $176.86.
176? Okay.
Yes,
Thank you very much.
thank you.
Representative Madigan.
Senator Claxton asked my question, so I'm good.
Okay, thank you. Any other questions for Dr. Ford? Yes, Representative Stover.
Thank you, Dr. Ford. I had a couple of questions. The first being, that's a fee for service rate and you don't receive any cost reimbursement. Is that correct?
Right, that's correct.
And then also, are you the only provider in the North for people with developmental disabilities who may need sedation in order to receive any dental care?
Yeah, that's correct. We actually see quite a few patients who are special needs that the only way that they can really be treated is in a center with more ability to control the environment. And our facility does do that.
I just want to say thank you for what you do.
Thank you.
Any other questions for Dr. Ford? Seeing none. Thank you for being here today.
Thank you very much for having me. I appreciate it.
Before we take the next testimony, Representatives Perry and Craven have joined us. Representative Perry, would you like to introduce yourself?
Yes, good morning. I'm Representative Ann Perry. I represent House District 140, which includes Baileyville, Barron, Cowles, Charlotte, Robbinston, Perry, Pembroke, and Pleasant Point.
And Representative Craven.
Madam Chair, apologies for being late. I'm Margaret Craven and I represent House District 59, which is part of Lewiston.
Up next in the queue is Newell Auger. Welcome, Newell.
Thank you, Chair Meyer and Dr. Claxton, members of the committee. I'll try to be very brief. I don't think I can improve upon what Dr. Ford has provided, and he is certainly the expert, being the only oral surgeon practicing north of Bangor. But I just would want to throw a couple additional thoughts in, and I do that mindful of the department's letter and mindful of the presentation that all of you received about the rate setting. And as someone who, I had Molly Bogart's job 20 years ago. I've been in this position with other providers, and I can appreciate the importance of a coordinated and planful rate setting review. And frankly, we were quite. And by the way, I'm sorry, and I'm a lawyer with Pierce Atwood, and here on behalf of Northern Maine Oral and maxillofacial surgery. The presentation that Director Probert made, I think, gave us certainly some encouragement in that I think among the 5 categories that she noted were most significantly in need of further study and perhaps further investment were a number of dental procedures, if you recall from that. And certainly we would believe that this reimbursement rate would fall squarely into that category. I don't think Dr. Ford went into it in too great a detail, but they have a significant backlog of main care referrals, perhaps over 1,000. When I was speaking to some of the women in his office who handled his scheduling, and the upshot of that is those folks go without care, and then have to go into the emergency room to get taken care of, which ultimately is not a good health outcome for them and costs the main care program significantly more money. And obviously, if he's one of the 2 remaining oral surgeons in the state taking main care patients without qualification, that's pretty significant. The other thing I would just add to that is, and if you'll recall from the presentation that Director Probert made, they talked about using numbers in the 5 other complementary states or from private pay. So this is admittedly, we are the only, Dr. Ford runs the only ASC that performs these dental alveolar procedures in Maine and maybe even in New England. So it's hard to put a square peg in a round hole on that. But and Medicare obviously does not provide dental services, so you can't use a Medicare rate, but you can use some of the private pay rates for the facility fee that is paid to the ambulatory surgical center. to offset the cost to maintain that ambulatory surgical center. And I think if you'll see in my written testimony, I noted that a number of the private pays are well above what the $178 that NFOMS receives. Blue Cross, yes, thank you. Blue Cross Blue Shield is about $810. The VA is at $810. That's usually a number we've used in the past. With the home care rate, certainly that was significant. And then I just would also note that in the complementary other 5 states that we've looked at, when there is no Medicare rate to compare to, Montana's rate for this precise reimbursement, the facility fee to the ASC, is $2,042. And now New Hampshire also has a rate of about $218, but again, it's a phantom rate because there are no ASCs in New Hampshire. So just something to think about. Again, we understand that the department is engaged in this rate review, but I think it's just important to note that, particularly given the issues that we talk about all the time about rural Maine having access to great healthcare. So I conclude my remarks there, and Ann Robinson and I would be happy. We'll be at the work session when you do work this bill.
Thank you, Mr. Auger. Questions for Newell Auger? Yes, Representative Zager.
Thank you, Madam Chair. Mr. Auger, thank you so much for testifying. I really appreciate any dental practice that accepts Maine care, and I appreciate that the value of doing it in a rural, underserved area, especially. I'm not clear about how this is the only. A couple times I've heard this is the only oral maxillofacial ambulatory surgical center in the state. Am I to understand that every oral and maxillofacial surgery that is occurring in the state is occurring as an inpatient?
Correct, and there are no other ASCs that perform dentoalveolar procedures. I mean, there are plenty that do gastroenterological or ophthalmological or orthopedic, but there's only one in Maine that does these procedures, and that can be those can be, they tend to be intricate dental procedures like removing impacted third molars, surgical exposure of an unerupted tooth, apiectomy, which I'm not going to even dare try to explain to you what is. We can recall Dr. Ford to give you a better description of that, but those types of complicated procedures that might otherwise have to be done in a hospital.
And the amount, it's about a tenfold increase in what's currently reimbursed. The amount, as I understand, was derived as to meet the costs. So it's reimbursed presently at 1/10 of what it basically costs to provide this to all those underserved patients in and around Prescott.
Well, I guess I would compare it to and we use the number 1250 because that seemed to be a middle ground between what Montana was paying, since they're the only one of the other 5 complementary states that actually are using this facility fee, and the private pay, which is somewhere in the 800 to 750 range. So the tenfold difference is really a reflection of how much these procedures on average would cost if they had to move into the hospital setting. And I think the important thing too to remember is there are patients that need to be where the procedure needs to be done in an ASC, as I think Representative Stover referred to, persons with severe autism or other mental health challenges. There are also specific procedures that can only take place in an ASC or a hospital. And if they don't take place in an ASC, on average, those procedures will cost about 10 times more.
So it's okay. So it's basically saying if this didn't occur in an ambulatory surgical center, it would cost that much, and so that's what main care ought to pay for it to be done in the ambulatory surgical center, which is arguably safer, more convenient, more accessible to the patient. That's the premise.
I think that's that's accurate.
Okay. Well, thank you. I appreciate that.
Any other questions for Newell Ober? Seeing none, thank you for being here today.
Thank you.
I do not see anyone else in the queue to provide testimony on 595. So I would ask the committee for any requests for additional information from our analyst for the work session. Seeing no requests, I will close the public hearing on LD 595 and open the public hearing on LD 512, which is an act to provide intensive case managers to counties that do not have county jails or regional jails, presented to us this morning by the bill's sponsor, Representative Jan Dodge. Welcome, Representative Dodge.
Good morning, Madam Chair. Thank you very much. Greetings to the committee. Good morning, Senator Claxton, Representative Meyer, and esteemed members of the Health and Human Services Committee. I am Representative Jan Dodge from House District 97, which includes Belfast, Northport, and Waldo. I am here to present LD 512, an act to provide intensive case managers to counties that do not have county jails or regional jails. I am here today, as I was in the 129th legislature, to advocate for people who suffer with mental illness or substance use disorder, or who have had an interaction with law enforcement that resulted in incarceration. For these people, an intensive case manager is the point person who aligns wraparound services to reduce the number of people with mental illness in our jails. This bill is focused on equity. Several counties have been sharing a case manager for years, and some years, even when positions have been added, they have not been assigned to the counties who share a case manager. This guided the drafting of this bill. These efforts have been ongoing and bipartisan. In 2017, the Stepping Up Initiative offered support for initiatives of this nature to continue. In the 128th legislature, former chairs of the Health and Human Services Committee, Representative Hymanson and Senator Brakey, sent a letter to then acting DHHS Commissioner Ricker Hamilton, recommending that LD 966, an act to create mental health liaison positions in each county jail, be carried over to allow 2 pilot projects to be undertaken in Androscoggin and Penobscot counties. In the 129th, LD 1756 attempted to improve public safety through coordinated reentry of prisoners into the community. A forensic case manager program established the shared services between Waldo, Knox, Lincoln, and Saginaw counties, which utilizes the Two Bridges facility and was the foundation for the current sharing of 1 intensive case manager position. This is to only name a few. A memorandum from the Office of Substance Abuse and Mental Health Services dated April 2019 states the program had 60 ICMs and 4 supervisors in 1990. In February 2020, Commissioner Lambrou testified before the Joint Standing Committees of Appropriations and Financial Affairs and Health and Human Services, page 14, item 52, FA 1908, and indicated there were 10 intensive case managers statewide. Evidence points to many people in our jails who might not be there if mental health and community supports were provided in a consistent way. Our Waldo County Reentry Center leadership recognized the value of ICM services and secured grants to supplement the current part-time position. Over the years, as intensive case manager positions have been added, they have not addressed the specific county need. Again, this bill is focused on equity. For Maine residents to benefit fairly from these invaluable services, it seems appropriate to establish a standard of 1 ICM per county. Please pass LD 512 to provide an intensive case manager for each county. I will try to answer your questions, but would ask that you direct your technical questions to those who have more expertise in this field than I. Thank you.
Thank you, Representative. Questions for the bill's sponsor? Seeing none. Nice to see you in our committee room this morning.
Thank you, Madam Chair. Thank you, Mr. Chair. Great to see you as well. Have a great day.
Testifying in support of this bill this morning, Bruce Nodden. Welcome. Mr. Nodden, here he is.
Good morning, sorry. Senator Claxton, Representative Meyer, and members of the Health and Human Services Committee. Thank you for welcoming me. My name is Bruce Nodden. I'm the Executive Director of the Maine Prisoner Reentry Network, or MPRN. We're a statewide nonprofit focused on providing peer support and coordinating community resources for hundreds of individuals returning to Maine communities from prison and jail. And we certainly support LD 512. In addition to MPRN's role as a support and resource connector, we have assembled and we represent a statewide network of literally hundreds of organizations committed to supporting returning citizens as part of a community resource plan tailored to each individual's needs. And the ICMs are a critical part of the network, especially in the more rural parts of Maine. ICMs have been invaluable in connecting individuals who are reentering and often in recovery to critical resources. Examples: housing, substance use treatment, PCPs, counseling, food, clothing, recovery, and spiritual supports. I think it's really important that I not get too technical about the stuff that we do and about kind of the challenges that are on the ground, but I think to just give an example of how this works already. So I'm going to single out one person in particular. Her name is Sherry Frazier, and she's an ICM in Washington County. She covers Washington and part of Hancock County. She was embedded in the jail in Washington County. We had a particular gentleman who was in his 60s, and was releasing from prison after a pretty lengthy stay. And we were really at a loss as to how we were going to connect him with the resources in Washington County, and we only had 1 or 2 connections there. And someone recommended that we reach out to Sherry. And Sherry joined us for a number of meetings at this particular facility via Zoom. And Sherry connected this gentleman with all of the resources that were critical to his needs and support. He had mental health support needs, substance use support needs. He required housing, supportive housing, and she connected him with all of those things. And I think it's really important that we kind of talk about, obviously the human effect for him is clear. But the effect to the community, and that's what we spend most of our time talking about. We can say that there are massive cost savings if this gentleman does not return to prison, and we can talk about that as far as the cost of how much it costs to stay in prison, but also that this gentleman is going to work. He's a taxpayer. The community is safer. We've kind of taken a bite out of chronic homelessness. And typically there are family and community connections that are made and community engagement that some really can't be measured. So for that reason, we support LD 512. I hope that folks also will reference Cullen Ryan's testimony, which he had a very extensive written testimony. And also he included, and many of us worked on this, Statewide Homeless Council's Maine Criminal Justice System Blueprint for ending and preventing homelessness. A large part of that identifies the need for intensive case management and an intensive case manager, not specifically in every county, but hopefully to increase those numbers of intensive case managers so that we can all work together as a team and see that ripple effect of helping one person who can have a real direct effect on the rest of the community. So thank you for allowing me to testify today.
Yes, thank you, Mr. Nodden. Questions? Yes, Representative Craven.
Thank you, Madam Chair. I really don't have a question. I just wanted to say hi to Bruce and say thank you for all of the work that you do in the community and in the state. And I am a co-signer on the bill, so you know that I'm a big supporter. So nice to see you.
Thank you, Representative Craven. Good to see you as well.
Any other questions? Seeing none, thank you for being here today.
Thank you.
Up next, Jan Collins, welcome. Ms. Collins? There she is.
Thank you
Welcome.
so much. It's an honor to follow Bruce Nodden in my testimony. Senator Claxton, Representative Meyer, and honorable members of the Health and Human Services Committee. My name is Jan Collins, and I am Assistant Director for Maine Prisoner Advocacy Coalition. I am also on the Board of Visitors for Franklin County Jail. And that is where I have been able to witness the great job that Bill Hall does. Although he's part-time, he is a great provider for care for inmates. And I'm here to support 512, an act to provide intensive case management. MPAC's mission is to support Maine's incarcerated citizens, their families and friends in their struggle with Maine's criminal justice system. Our purpose is to reduce Maine's use of incarceration by creating a criminal justice system that is ethical, humane, and restorative in nature, just as Mr. Nodden was talking about. Many thanks to Representative Dodge for bringing this bill forward. LD 512 creates equity for the residents of Maine counties who do not maintain a local jail. It creates the supports that are necessary to keep individuals with medical conditions out of jail, or if unavoidable, to help them re-enter their community successfully with supports. Since the early 1980s, the percentage of people incarcerated in the United States has increased 700%, primarily because we have chosen to put people with medical conditions in jail or prison instead of treating their condition. In Maine, we deinstitutionalize people with mental health conditions without providing the necessary community supports, and we started incarcerating people with substance use disorder. Ask any sheriff, and I see that we have a sheriff here to speak today, in any county, and they will tell you they are the social service provider of last resort. Steve Gordon, Cumberland County Commissioner, stated in November Department of Corrections policy hearing that over 70% of inmates at Cumberland County Jail were prescribed psychotropic medications. It is the role of the intensive case manager to put in place services to stabilize healthcare while the person is in custody, ensure their right to a speedy trial, and to connect them with providers in the community who can support them when they are released. All of these steps honor the humanity of the people in custody and treat medical conditions with medical solutions, enhancing the individual's success and healing the fabric of our communities. Please support LD 512, and thank you so much for your consideration.
Thank you for being here this morning. Questions for Ms. Collins? Seeing none. Up, Senator Claxton.
Nope, no thank you.
That was a no?
That was a no. I'm all set.
Okay. Thank you, Ms. Collins, for being here today for your testimony.
And thank you for the opportunity.
Up next is Mr. Trafton, Jeffrey Trafton.
Thank you. Senator Claxton, Representative Mayor, and esteemed members of the Joint Standing Committee on Health and Human Services. My name is Jeff Trafton. I'm the sheriff in Waldo County, and I'm here on behalf of the Maine Sheriff's Association. I offer this written testimony in support of LD 512, an act to provide intensive case managers to counties that do not have county jails or regional jails. Waldo County is one of those counties that does not have a traditional jail. We operate a 72-hour booking facility and a 32-bed reentry center. We currently share an intensive case manager with 3 other counties in the Mid-Coast area. The result of this sharing is that inmates incarcerated in Waldo County receive almost no services simply because it's not humanly possible for one ICM to adequately serve the inmates in 4 counties. The intensive case managers specialize in assisting folks who are in custody who are suffering from substance abuse disorder and mental health issues. Over the past 3 years, our booking facility alone has processed more than 3,200 people into custody. 788 of those individuals were booked into the facility, were processed more than 3 times. 424 of those displayed co-occurring issues of both substance abuse and mental health issues. 309 of them displayed only substance abuse disorder and 19 displayed only mental health issues. This leaves only 36 of the 788 who had no indication of substance abuse disorder or mental health problems. There is a critical need for the services provided by the intensive case managers. Maine sheriffs believe that providing a minimum of 1 case manager to each county facility will result in a much higher number of these at-risk populations receiving the critical help they need to address these issues. We also believe it will help in our unified efforts to decrease the high level of recidivism we see in our counties statewide. The Maine Sheriff's Association deeply appreciates your consideration, and I would be pleased to answer any questions you may have. Thank you.
Thank you, Sheriff. Any questions for Sheriff Trafton? Seeing none. Thanks for being here today.
Thank you.
Oh, I'm sorry, Sheriff, Representative Craven.
Thank you, Madam Chair. Thank you, Sheriff, for coming.
Welcome.
What happens to all of those people that fall through the cracks and that don't have any services once they leave their incarceration?
Well, unfortunately, many of them return to our jail over time. That's why when we put this testimony together, I wanted to show that over 3 years, we had 788 folks that came back to our facility several times and displaying these kinds of issues, substance abuse disorder and mental health issues. So we have gotten some grants. We've worked other avenues to try to provide some of these services, working with other organizations around the state. So we have had some success, and we try to get these folks, because when they come to the county sheriffs, we're sort of the ER of jails, because they come into us and they're usually in crisis. And so we work as hard as we can with the existing resources that we have, which is not enough, but we try to take care of some of their needs and bring them out of crisis before they're released back into society. And but unfortunately, many of these folks do fall through the cracks, or a Band-Aid is put on their situation and they're sent back into society, not prepared and not properly resourced to help their issues.
Thank you. Any other questions for the sheriff? Seeing none. That concludes the testimony on LD 512. So I will close the public hearing on 512 and open the public hearing on LD 674, an act to support early intervention and treatment of psychotic disorders. Yes, Representative Zager.
Thank you, Madam Chair. I just wanted to request something for the work session before we
I completely blew past that. Thank you. Questions for our or requests for additional information from our analyst on 595 on 512. Yes, Representative Zager.
Thank you, Madam Chair. I was looking at the fiscal note. looked like it was approximately, for 4 positions, it was approximately $400,000. I'm very much in favor of investing in upstream things and not treating illnesses, substance use disorder, like, not to criminalize it. However, I'd be interested in more detail for the work session on how that compares to other ICM's positions, how that number was derived essentially.
Thank you. Did I see another raised hand looking for, I don't think so. I do remember there was some correspondence that went back and forth about some amendments to this LD. Erin, do we?
Representative Dodge submitted her proposed amendment through the portal.
Okay. Okay, now I believe we can close the public hearing on 512. I'm seeing that the bill 674 sponsor, Senator Breen, is going to need a few minutes. And I would ask that we take it looks like maybe a 5-minute break and come back and see if the sponsor of 674 is available. See you at 10:50. welcome back. Just give a few of our members a chance to return to their desks.
Madam Chair, oh, there we go. I was getting an error message saying that I was unable to restart my video. I apologize. But it looks
All
like
set?
Yep.
There we go. Welcome back. I see the sponsor of 674 has joined us. So I will open the public hearing on LD 674, an act to support early intervention and treatment of psychotic disorders, and welcome the bill's sponsor, Senator Kathy Breen. Welcome.
Thank you so much, Madam Chair, and thank you to everybody on the committee who was able to give me a little flexibility today, and thank you for your patience. Representative Meyer, Senator Claxton, and everybody on the HHS committee. My name is Kathy Breen. I represent 6.5 communities in Cumberland County, and I'm here to introduce LD 674, an act to support early intervention and treatment of psychotic disorders. For those of you who are returning to HHS, this bill might be familiar to you from last session. For many decades, research and clinical experience have proven that chronic serious diseases like diabetes, heart disease, and cancer respond best to prevention, early detection, and early intervention. We know that when patients and their families pay attention to early warning signs of these diseases, they should address them promptly and get to the doctor immediately. Doing so can result in early detection and effective treatment at the beginning stages of serious illness. This early detection and intervention in most cases will result in better long-term outcomes and lower overall costs to the healthcare system that we all support through insurance and taxes. For example, gone are the days when a woman experiences shortness of breath, nausea, and pain in her arms and thinks, maybe if I ignore all this, it will go away. Gone are the days when a response to a loved one who experiences blurry vision, dramatic weight loss, and extreme fatigue is, well, honey, give it some time to work itself out. You're being dramatic. And when was the last time you heard an oncologist say, your cancer is probably at stage 1. Let's wait until it reaches stage 4 until we treat it. Come back in 6 months. I think you see my point. This is the old and familiar part of the story. The new and exciting part of this story is this. Can the same prevention and early treatment principles and improved results be applied to chronic and serious mental illnesses? And I have good news for you. The answer is yes. And that's what this bill is about. We've all heard and maybe even used the word psychotic in casual conversations, taking it to mean crazy, out of control, unpredictable. But psychosis is a key symptom of some of the most devastating chronic mental illnesses, like schizophrenia and bipolar disorder. According to the National Institute on Mental Health, the word psychosis is used to describe conditions that affect the mind where there has been some loss of contact with reality. When someone becomes ill in this way, it is called a psychotic episode. During a period of psychosis, a person's thoughts and perceptions are disturbed, and an individual may have difficulty understanding what is real and what is not. Symptoms of psychosis include delusions, meaning false beliefs, hallucinations, like seeing or hearing things that others do not see or hear. Other symptoms include incoherent or nonsense speech and behavior that is inappropriate for the situation. A person in a psychotic episode may experience depression, anxiety, sleep problems, social withdrawal, lack of motivation, and difficulty functioning overall. People living with psychosis are some of the most vulnerable people in our communities. They're most prone to unemployment, homelessness, persistent hunger, being on the receiving end of abuse and violence, and undergoing repeated hospitalizations and incarceration. Without access to effective treatments, Folks with these illnesses may cut ties with their loved ones, misperceiving attempts to help as threats. They're at very high risk for substance use disorder and long-term addiction, along with other co-occurring health problems. They can wander in and out of hospitals, jails, and homeless shelters for years, with only local providers, if anyone, knowing their whereabouts. A friend in my district has a young adult son who was missing for close to 2 years. After enduring this unimaginable heartache, the family got a call from the American consulate in New Zealand, asking them to come and pick up their very ill son. They managed to get him home safely, but the young man had no memory of how or why he'd landed on the other side of the planet. Even with proper medication that suppresses psychosis, functional impairment can be profound. There's no medication for the deterioration in cognitive and social functioning that typically accompanies these illnesses. Furthermore, all of these medications that do treat psychosis have some serious side effects like weight gain, which can lead to obesity and obesity-related disorders such as diabetes. There are some known factors about the typical onset of these illnesses and their trajectory over time. For instance, typical onset is in late adolescence and early adulthood, precisely the developmental stages when young people are pulling away from all they've known as children, increasing stress and emotional isolation. Next, we know there are strong genetic factors. Lastly, we know that most of these illnesses progress for months and sometimes even years before any evaluation or treatment is sought. As some of you might know, Maine Medical Center has been in the forefront of cutting-edge research, prevention, and early intervention in the arena of psychotic disorders. You'll hear more about the specifics of the progress that Maine Med is making from others who follow me today. But let me be clear and direct. This work is a game changer. Preventing and/or intervening in early psychotic disorders is the single most dramatic step we've seen in many decades for people living with psychotic disorders. You'll hear more about the return on investment in future comments. LD 674 directs the Department of Health and Human Services to develop a funding and reimbursement mechanism for the treatment of Mainers who show signs of psychotic disorder in the early stages. This work at Maine Med, known as Coordinated Specialty Care, you can see the attached fact sheet that came with my testimony. This work has been partially supported by Medicaid and by a federal grant for the past few years. It's been limited to only this one site in Maine, and there's already demand in other areas of Maine, and even some training that's already happening. But only Maine Med has had the federal grant that's critical to support the coordinated specialty care aspect of the program, and that grant has now expired. COVID-19 has underscored the need for additional funding for this program. The program that's known as PEER has transitioned to delivering care almost exclusively via telehealth, as many other providers have at the onset of the pandemic. They're expanding through telehealth their reach well beyond the greater Portland area. However, bringing the single coordinated specialty care program in Maine to the more rural parts of our state has resulted in a long wait list and exposed how truly inadequate the existing funding is to staff this level of care. We now need to develop a bundled rate and code that providers can use with private insurers and Maine Care to implement this model all over Maine. I'm going to say that again because I messed it up. We now need to develop a bundled rate and code that providers can use with private insurance providers and Maine Care to implement this model all over Maine. Someday soon, chronic, often devastating psychotic mental illnesses will be managed like diabetes, heart disease, and cancer, where early warning signs are widely recognized and acted on, preventing the onset of psychosis altogether or vastly improving the outcomes in patients' lives and resources spent. I hope you can see my excitement about this and that you will share it after today's public hearing. I thank you very much for your attention, and I'd be happy to take any questions.
Thank you, Senator. Questions from the committee for the bill sponsor? Seeing none. Senator Breen, we are not finding your testimony and the attachment you referenced in our online file cabinet.
Okay.
If you would resubmit that, please, through the portal so that the committee could
Absolutely.
have
I
access to that.
apologize for that technical glitch, and I will rectify that immediately.
Thank you so much, and thank you for sponsoring this important bill. Up next, providing testimony, Douglas Robbins. You'll need to unmute yourself, please.
Good morning, Senator Claxton, Representative Mayer, and distinguished members of the Joint Standing Committee on Health and Human Services. I appreciate the opportunity to address the critical need for LD 674 to support early intervention and treatment of severe mental health disorders, particularly psychotic disorders. I am a child and adolescent psychiatrist and a clinical professor of psychiatry at Tufts University Medical School. For 20 years, I was the director of the Division of Child and Adolescent Psychiatry at Maine Medical Center, and I continue now in Maine Health's community mental health system, Maine Behavioral Health Care. I served as director of the PEER, which is Portland Identification and Early Referral Program for Early Psychosis, from its receipt of a, particularly from its receipt of a federal grant in 2015 to focus on what's called first episode psychosis through 2018. I'm also the co-chair of a national work group sponsored by the National Alliance on Mental Illness, focusing on the financial issues in making this evidence-based treatment available, financing early psychosis treatment, which is a major barrier to its being disseminated and implemented. This bill will bring effective treatment to hundreds of Mainers with severe disabling mental illness. It focuses on early intervention in disorders with the symptoms of psychosis, which Senator Breen described very well. Hallucinations, delusions, and disorganized thinking. The diagnoses associated with these symptoms are typically schizophrenia, severe bipolar disorder, severe major depressive disorder, and some others. These include approximately 3% of the population, or about 39,000 people today in Maine. They are often severely disabling, resulting in disruptions of relationships with family, inability to complete education, to work, law enforcement contacts, quite consistent with what you just heard about in the testimony for LD 512, I should say, with incarceration becoming the outcome for many people with substance abuse and mental health needs. Disruption of relationships with the family, inability to complete one's education or work. I'm repeating myself, sorry about that. Homelessness and shortened lives due to medical illness and suicide. There's a approximately 25-year earlier mortality in people with these illnesses. Until recently, effects of treatment have been seriously limited, but we now have an evidence-based intervention that can improve people's lives. It's called coordinated specialty care. It's a team-based model, which includes family support, recovery-based psychotherapy, educational and vocational support, peer mentor support, active outreach, and targeted medication.
30
Sarah,
seconds.
yes?
30 seconds.
The key thing is that this is cost effective. Multiple studies have shown that a limited increase in outpatient cost results in less need for hospitalization and a net decrease in healthcare costs, saving nearly $3,000 per patient in the very first year of treatment. If we treat 140 patients annually in Maine, this results in a savings of approximately $420,000. This is a clear example of population health and value-based healthcare and sound fiscal healthcare policy. I strongly encourage the legislature to support this initiative, and I appreciate Senator Breen and others bringing it forward.
Thank you for being here today. Questions for Dr. Robbins? Did you also submit written testimony?
Yes, I have.
Okay, because I am not seeing, I see your name, but I don't see an associated.
Okay.
So if you could resubmit your testimony, it's helpful to have that.
We will do that this morning. I've also sent to the DHHS Office of Fiscal and Program review a more detailed fact sheet about cost effectiveness, return on investment, which is probably more than the committee wants to get into. But I'm willing to. I very much want to make sure this is done well.
Thank you, sir. Up next, yes, Senator Claxton.
I'd like to make sure that detail is available as part of the committee testimony. This group is not reluctant to get into the weeds, sir. Thank you.
I will be glad to send you a wheelbarrow full of weeds.
Thank you.
He speaks the truth. Up next in the queue is Elias Pierce. Am I seeing Mr. Pierce? I do not, so we will move on to Elizabeth Oakleaf, and if Elias returns, we will hear his testimony. So welcome, Ms. Oakleaf.
Thank you very much, Senator Claxton, Representative Meyer, and members of the committee. My name is Elizabeth Oakleaf, and I'm here today to testify in strong support of LD 674. I'm a parent of a young adult who in hindsight began to develop mental health issues in high school. I didn't realize it was more than typical adolescent issues. I started to get a sense something more was wrong when she decided to drive to California the spring of her freshman year in college. She ended up asking me for help, struggling with paranoia and feeling suicidal. I went to California to set up supports for her, but sobbing, she told me I didn't understand. Her brain wasn't working the way it used to. I ended up taking her home. My daughter graduated third in her high school class. She wanted to be a doctor, but her thoughts and behaviors had changed and it was getting worse. The quickest option was to see her PCP, who diagnosed her with bipolar disorder and referred her to a psychiatrist who had 272 patients on her caseload, room for an appointment every 3 months, and didn't respond to phone calls. I called 34 therapists who were either full or didn't feel equipped to offer services to my daughter. The last therapist I spoke with recommended the peer program. 14 years later, I will tell you the peer program coordinated level of care laid the foundation for a better future for my daughter, who is now living on her own the last 2 years. It wasn't easy. It took a long time with many bumps in the road. She worked with a team and we attended multifamily group, working together on problem solving. I must tell you, she had been to providers before, who assume parents are a part of the problem. It was a relief that the peer program involves family as a part of the solution, which makes a real difference. Why? Because it does take a village. It takes a team of people that provides coordinated care, rather than a psychiatrist in one office, a therapist in another, and most likely no peer or vocational supports. With coordinated care, the young adult and their family learn together how to manage and get ahead of these illnesses. The standard model does not provide this robust level of care. Coordinated care matters because time matters. It has been proven to alter the trajectory of these illnesses. Robust care allows us to get ahead of the damage that might be done to the brains of these young people with lesser treatment. The person and their family learn to better manage their illness, to prevent it from worsening, and to avoid multiple hospitalizations. A coordinated level of mental health care can reduce the ongoing burden of mental illness for the person, their family, and society. For full disclosure, as a result of my experiences, I went back to school, earned a master's in social work, then my LCSW, and I'm currently working at Spring Harbor Hospital as a family navigator. Over the last 5.5 years, I've supported several thousand families of inpatient loved ones. I'm familiar with their struggles. I know how the system is failing many young people and their families. So I'm asking you to please support LD 674 to help these young people so they can have a better future. Thank you for your time, and I'm happy to answer any questions you may have.
Questions from the committee from Ms. Oakleaf? Seeing none. Thank you for being here today. Up next in the queue is the Honorable Jeff Gratwick. Welcome, Dr. Gratwick.
Good morning. Morning, former colleagues, and I'm both, I think I know most of you really moderately well, and it's both a great pleasure to be away from you and a great sadness to be away from you. So life is not simple. But Representative Meyer and Senator Claxton and all of my other honorable colleagues, Jeff Gratwick, I'm a retired physician living in Bangor and was very supportive of this legislation when it came last year, and again, and so this year. The reasons to support this legislation is that it will save money. And I think we're all aware that early intervention makes an enormous difference. So that if you have diabetes or heart disease or hypertension, whatever it be, early treatment makes the difference of whether you're going to lead a productive life or not. And exactly the same is true for psychiatric illnesses. And the thing about the peer that appeals to me is a team approach. And unfortunately, somebody amongst us, or someone's going to have some pain in their chest at some point, or their right lower quadrant for their appendix or whatever, and they're going to need further care. They're going to go to the emergency room where they're going to be seen by a triage nurse. They're going to be seen by a regular nurse. They'll probably be seen by a physician, a laboratory technician. There'll be a security guard at the door, someone to help with parking. There'll be some housekeeping who has kept the room clean and so forth. They'll need surgical supply. You'll need to have some administrator figures out what to do. You certainly need a social worker, and i.e. the point is that medicine these days is a team approach. Team approaches work, and this is certainly an instance in which there's good data. A team approach for psychiatric illnesses of this ilk, when applied early, make it.
We appear to have lost Dr. Gratwick. Dr. Gratwick, we've lost you. Your video and your audio. There he is. You're back, but you're frozen.
Okay, I'm sorry.
Go ahead, you're back. You're back.
I live
Complete
in
your
the
testimony.
I live in the far reaches of the state, which is, say, Bangor. So who could tell? Anyway,
Can you try shutting off your video?
You want to shut down your video, Dr. Gratwick?
Yes.
And then just.
Now, and if so, if need be, I only have about 90 seconds left. My only other is that people with illness are just like all.
I'm sorry, Dr. Gratwick. We're not even hearing you now.
Okay, I will call in by telephone and finish up. My apologies.
Okay.
I think you cannot.
Actually, we do have your audio now. It's in and out.
Yeah. Well, this is a broadband.
Yeah. If you want to shut down and call in, you can finish up your testimony and we'll move on to the next in the queue.
I'll do so. Thank you.
Thank you, Dr. Gratwick. Again, apologies as we continue to iron out the wrinkles daily of committee work in the virtual environment. Up next in the queue is Hannah Longley. Ms. Longley.
Good morning, Senator Claxton, Representative Meyer, and esteemed members of the committee. My name's Hannah Longley. I'm representing NAMI, Maine. As the state's largest grassroots mental health advocacy organization, NAMI Maine supports the passage of LD 674, an act to support early intervention and treatment of psychotic disorders. Maine has led the field in the development and implementation of an evidence-based early intervention program for young people developing a severe and persistent mental illness. As other states have adopted the model, Maine has fallen behind in the expansion of this proven service. The programming that would be offered under this bill would be both life-saving as well as life-changing for those who would utilize it. While 1 in 40 Americans will experience a severe and persistent mental illness across their lifetime, less than half will receive an adequate and effective intervention prior to their illness progressing to the point of meeting criteria for a disability. Psychosis typically emerges during late adolescence and early adulthood,
Thank you so much.
which is a critical time period in which education and vocational skills are often developed and honed to assist with the tremendous transition into independent adulthood. By providing proactive and early interventions, individuals will have the skills and tools to successfully make this transition. Early intervention has been found effective in assisting in long-term recovery, greater educational and vocational achievements, as well as decreasing the risk for developing a substance use disorder or involvement in the criminal justice system. Sadly, 20% of young people who develop a severe and persistent mental illness receive their first formal intervention during an encounter with law enforcement. Early intervention assists in providing services necessary to support the young person through their illness and treat it effectively, increasing the likelihood of positive outcomes. NAMI Maine hears from individuals and their family members frequently seeking out treatment for a severe and persistent mental illness. Sadly, there's some joy when we find out that the individual is residing in the Portland area and able to access the peer program. We owe it to individuals who live in other parts of our great state to provide the same standard of care and treatment availability as is found in Portland. NAMI Maine understands that the state is in a difficult fiscal position during these times. However, providing early intervention is a cost-saving measure. The average cost of inpatient hospitalization for an individual experiencing a severe and persistent mental illness is between $20,000 and $24,000. Early intervention and treatment has been found to decrease hospitalizations and costly involvement in the criminal justice system, as well as increase the capacity for independent and fulfilling lives, decreasing the necessity of far more expensive interventions and treatments later in life. We would not question early intervention measures as it relates to physical health conditions such as cancer, heart disease, or diabetes. We should not question early intervention for mental illness either.
Thank you, Ms. Longley. Questions from the committee for Ms. Longley? Yes, Representative Madigan.
I just wanted to welcome Hannah. I've known her for a number of years and she does amazing work. Good to see you and thanks for speaking up.
Thank you, Colleen. It's nice to see you.
Seeing no other questions, we thank you for being here today. So it is my understanding that Dr. Gratwick is now on the telephone, so we will allow Dr. Gratwick to finish his testimony. Jeff, you'll need to unmute yourself.
Can you hear me now, please?
We can.
Thank you, and my apologies not for living in Bangor, but for not having adequate broadband. So I guess you said that the idea that there's a team approach is very reasonable for many areas of medicine, this being another one. The second, I was just beginning to talk about the fact that many people with psychiatric illnesses can lead very, very normal lives and be highly productive. And I would simply say that in a very personal way, I've had an individual in my larger family unit who had this problem and lived in Rochester. I talked to the doctors Robbins and McFarland in Portland. They were able to find people in Rochester, and it's made an enormous difference in this family member's life. And so I have a very personal acquaintanceship with it. And the third thing is money. We always talk about money, and the fiscal note last year was $1.2 million. And I've talked with Luke Lazur, and Doctors McFarland, Robbins et al. Are going to be getting more data that you'll be getting about the long-term savings. So this is really a situation where if we spend money now, we'll save a lot of money later. But this is going to be up to appropriations. But it seems like a very reasonable expenditure of funds, even in these very hard times. I'm happy to answer any questions. And again, it's a pleasure to be back with you in a sense. Thank you.
Thank you, Dr. Gratwick. Questions from the committee? Yes, I thought I saw Representative Craven's hand up, but it's now down. No, it is up. Representative Craven and then Senator Moore.
Thank you. Thank you, Madam Chair. I just wanted to let Dr. Gratwick know that we miss his flowers and all of the brightness that he brought to the committee.
Representative Craven, many of the lights in my life have gone out since I no longer see you, but I will promise to bring flowers and indeed goodies when I come next. Thank you.
Senator Moore.
And that was my exact sentiments. I was going to say, now you're supposed to bring us some goodies when you come visit the HHS committee again. So we look forward to being able to see you in person, Dr. Gratwick. Thank you.
Thank you very much, Senator Moore.
I echo those sentiments. Up next, so we'll go to Julie Shermer, followed by Elias Pierce.
Good morning, Representative Meyer, Senator Claxton, and esteemed members of the Health and Human Services Committee. My name is Julie Shermer. I am a clinical social worker, and I represent National Association of Social Workers, the main chapter of which we have over 800 members, and we represent over 5,000 licensed clinical social workers in the state. So I am passionate about this for multiple reasons. Professionally, I have witnessed and seen both the travesties of these young people losing their productive lives with untreated schizophrenia, as well as I've seen wonderful cases of people who have had early intervention, and 10 years after seeing them, running into them and them telling me how they are living productive lives and have families of their own. And sometimes they are oftentimes the strongest ones in their families. In my testimony that I have submitted, I have provided just a few key pieces of evidence that show how comprehensive coordinated specialty care really shows significant improvements in employment, in well-being, in mental health recovery, and in overall education and productivity. And those among us, Dr. Robinson certainly has the figures in terms of cost savings. The really major reason why I'm so committed to this issue is I am from a family where 2 of my 4 siblings have psychotic disorders, and my mother developed a psychotic disorder in her 50s. So I have witnessed and seen the difficulties of getting treatment. I am so thankful that I'm one of those lucky ones who did not get the genes for this. I I have one of my brothers. My brother is doing tremendously well. My sister, not so well. 5 years ago, I helped her on her 7th of 8 commitments in 1 year, where she was out of the hospital more than she was in the hospital. So I'm one of those people who have been part of the team, but I've been part of the family team on with folks with severe and profound sequelae from psychosis. For heartfelt reasons, and despite all the stats, just kind of the emotional reasons, this is a really important piece of legislation, and I urge you all to support it.
We thank you for your testimony today. Senator Claxton, question for Ms. Shermer.
Thank you, Madam Chair. And we usually use leave greetings to Representative Craven, but I've had the distinct pleasure in my professional career of overlapping with Ms. Shermer for about 15 years. And I loved watching her work and the talent that she brings to it. And this is my opportunity to say hello and welcome.
Thank you, Senator Claxton.
Representative Zager.
Thank you, Madam Chair. I will echo that as well. Ms. Shermer has been one of my teachers, and I've also appreciated the way that that you've blended your professional expertise and your advocacy, and now with today's testimony, your personal story. Really great to see you.
Thanks, Sam.
Thank you. Up next in the queue is Elias Pierce. Welcome.
Thank you so much, and sorry about the technical difficulties earlier. I was able to see everyone, but I was not showing up on the video. Senator Claxton, Representative Meyer, and members of the committee, my name is Elias Pierce, and I'm here today to testify in strong support of LD 674. A little over 3 years ago, spurred by an onslaught of intrusive, unwanted thoughts, I checked myself into Spring Harbor Acute Care Psychiatric Ward, worried that I would commit suicide. My speech had slowed, wending its way with pent-up intensity through thickets of peripherally relevant thoughts, and I shook uncontrollably. Most of the time, I didn't say anything at all. The previous night, I'd spent 8 hours trying to write the college recommendations I'd committed to sending in my role as a high school English teacher. I maybe wrote 2 paragraphs. I'd always been a strong student, receiving a prestigious scholarship that funded my private school education, winning a departmental award for a story I wrote as a senior at Bowdoin College. So losing my grip on language was unnerving, but not nearly as unnerving as the violence with which my worries pinged around my head. One night in the hospital, I woke in the middle of a panic attack that raised my body temperature more than a degree. I'd certainly shot myself in the foot before by overthinking, but this was an unprecedented revolt of my brain against itself. I left the hospital with a diagnosis of anxiety-induced psychosis, depression, and OCD. I had very little control over where my thoughts landed at any given moment. The team at Peer helped me take back that control. Through a targeted effort that included cognitive behavioral therapy, counseling, exercise, family meetings, multifamily problem-solving sessions, and medication, I began painfully slowly to re-inhabit my old wit and logic. It was many days before I laughed, a pained bark foreign to my own ears. It was months after that I finally internalized the truth that sometimes the most profound response to a problem is to look away. Not everything can be figured out. With the help of my therapists, I learned that it is often easier to act one's way into new thought patterns than to think one's way into new ways of acting. The body, as they say, keeps the score even when the mind has gone out to lunch, so to speak. The moment when I got the results of my neuropsychological evaluation nearly 6 months after I left the hospital was among the most validating of my life. There it was, laid out in front of me by a professional with years of experience. Something was wrong with my brain. I have Pierre to thank that when she told me I likely would never know exactly why. The years before my episode of psychosis had been marked by dengue fevers, seemingly inescapable fatigue, 2 concussions, a moped accident in which I hit a 65-year-old woman walking in the middle of an unlit road at night, and a relationship that forced me to confront my issues with emotional honesty. I accepted the ambiguity and moved on. More than a year after my evaluation, I am in a committed relationship with a woman I plan to marry. I had the best season of rock climbing of my life last fall, and I was just accepted to artist residency this summer for the month of August, where I plan to write fiction. There's no doubt in my mind that the facets characteristic of coordinated care made my recovery possible. My providers' communication with each other, with my parents, and with my future caregivers after I transitioned out of the program created an environment of trust, transparency, and powerful action that swept me off my feet. It's hard to follow when your safety net is a mile wide. Even though I feel like a different person now than when I started Peer, and the differences are pronounced, sometimes I wish my parents had filmed me during one of our nightly meandering conversations, back clenched and jaw clenched in hypervigilant introspection, just so I could see how it looked from the outside. Walking into 66 Bramwell Street still feels like a coming home. I'm confident it always will. Expanding access to coordinated care for early psychosis would make radical change in the lives of Mainers on the fringes of themselves. Coordinated care creates community in the face of crushing loneliness, hope in the face of fear, and time in the face of months collapsing in on themselves with brutal gravity. It's a long life. Please let coordinated care help those with early psychosis live theirs. Respectfully, Elias Peirce.
Thank you, Elias. Questions for Mr. Peirce? Seeing none, I want to thank you for being here today and delivering that powerful testimony. Impactful. Yep, up next in the queue is Karen Kleinkopf. Welcome.
Thank you. Hello, Senators Claxton, Representative Meyer, and distinguished members of the Joint Standing Committee on Health and Human Services. My name is Karen Kleinkopf, and I'm here today to testify in strong support of LD 674, an act to support early intervention and treatment of psychotic disorders. When our daughter was a sophomore in high school, we started to notice that there were subtle changes in her thinking. Initially, we had her seen by our local pediatrician and psychiatrist and were reassured that we were seeing what we were seeing was likely due to little sleep and too much social media use. Unfortunately, just before she started her junior year of high school, she developed very disorganized thinking and manic symptoms. She again saw our local psychiatrist and was diagnosed with bipolar disorder and started on medication. She refused recommended counseling. While the medicine helped, she continued to have periodic exasperations, and our family felt like we didn't have much guidance or support. Then just before starting her senior year of high school, she had another particularly bad manic episode. We knew we needed to do something different and reached out to the peer program that we had heard of. That same day, the social worker called us back, learned our story, spoke with our daughter, and made arrangements for us to come down to Portland and meet with the team the next day. Over the past 2.5 years, we have participated in many of the programs that peer offers, including counseling for both our daughter and our family, visits with the peer psychiatrist, meeting with a vocational education specialist, meetings with other families in settings inclusive of the patient with symptoms and siblings, and meetings just for parents. While the peer program has not fixed all our problems, it has given us a multitude of resources for building on our strength, identifying problems early on, and most importantly, preserving hope that we as a family and our daughter can look forward to a bright future. Currently, our daughter is a full-time student at the University of Maine, Farmington, and has declared her major in early childhood education, special ed. And she works as well. While the local medical and psychiatric and social work providers are well-meaning and try to be helpful, the current system of psychiatric care is incredibly fragmented and often difficult to access. The well-coordinated and comprehensive approach offered by peer is vastly superior and deserves to be made much more widely available. To participate in peer, our family has made many 90-minute trips from Damascotta to Portland. We have been happy to invest that time in our daughter's future, but where you live in Maine should not dictate whether or not your child can receive high-quality psychiatric care. We strongly encourage you to support this legislation so families across the state can have access to the resources that have made so much of a difference for our family and our daughter. Sincerely, Karen Kleinkoff, and it includes my husband, Tim Goltz, MD.
Thank you. Questions for Ms. Kleinkoff? Seeing none, thank you for being here today. Up next in the queue is Mallory Shaughnessy.
Hi, can you hear me okay?
We can.
Great. Good morning, Senator Claxton, Representative Meyer, members of the Joint Standing Committee on Health and Human Services. As you know, I am Mallory Shaughnessy, resident of Westbrook and the Executive Director of the Alliance for Addiction and Mental Health Services. We thank you for the opportunity to speak very strongly in support of LD 674 this morning. As you've been hearing from others, compared to typical care for first episode psychosis, coordinated specialty care has been shown to be the more effective at reducing symptoms, improving quality of life, and increasing involvement in work or school. You've already heard a lot of data. I just want you to take a moment to think of all the testimony this committee has heard over the years, seeking investments in community treatment and support for adults struggling with severe psychiatric disorders, the adults that didn't get critical early help, that unfortunately too often cycle through the system due to severe mental illness, those that all too well know the insides of our county jails, the stark rooms in our emergency departments where they can languish for days or weeks on end, and the streets in our communities where they too often find themselves. And now picture the person living in your community with a psychiatric illness who received the early care. You've been hearing some stories. It met their needs. There are many out there, you don't hear from them or hear about them in the same way, but they received the treatment that helped to stabilize them, it allowed them to go on, achieve an education, pursue a career, have a family, contribute to their community, and live their best life. Think about these two scenarios, and we all know the one we want to see. So the members of the Alliance believe this critical service needs to be available throughout the state for anyone who needs this service, that young people struggling with their first episode psychosis and their families deserve no less. I know the department is moving towards this, incorporating this, but we need to move faster. And I just, for all the young people and their families, please support LD 674. And I'd be happy to answer any questions or get any information that you might need.
Thank you. Questions for Ms. Shaughnessy? Seeing none, nice to see you here today.
Thank you for your work.
And finally in the queue is Sarah Lynch. Welcome.
Thank you. Can you hear me?
We can.
Okay. Senator Claxton, Representative Meyer, and distinguished members of the Joint Standing Committee on Health and Human Services. My name is Sarah Lynch, and I am here today to testify in strong support of LD 674. I'm the program manager of the Portland Identification and Early Referral, or PEER program. I joined the PEER team 20 years ago when it was under the leadership of Dr. William McFarland. And it supporting these young people and families and all the success stories has influenced me and now become my life's work. PEER is nationally recognized leader in research, training, and gold standard team-based and family-involved care that can mean the difference between a young person being chronically disabled and living a productive and meaningful life. The World Health Organization recommends evidence-based treatment be provided within 3 to 4 months of a first episode of psychosis, because there is a critical window of opportunity to make this difference. For most Mainers, the delay to treatment is months or years longer, and for treatment that includes only individual therapy or medication. Sadly, our current system waits for people to prove a level of disability before offering more assertive, comprehensive treatment that is less effective because it is offered too late. Coordinated specialty care, or CSC, works because individual therapy and psychopharmacology are complemented by a range of non-billable components. These include community education to identify youth early, supported education and employment to engage young people in goals that matter to them, peer support to facilitate connection and hope, and twice-a-week team meetings and impromptu collaboration to monitor and respond to early warning signs and avert crises and expensive hospitalizations. Coordinated team-based care relies heavily on mental health block grant funding, which is temporary. PEER is currently the only early psychosis CSC team in the state. And in the last 5 years, we have served 180 young people and their families, mostly from Southern Maine. With telehealth expansion since the pandemic, we now serve people from Androscoggin, Aroostook, Knox, Kennebec, Lincoln, Oxford, Somerset, and Waldo counties. We have doubled our census, but the wait for care is now 3 months outside of the recommended window of opportunity. Meeting the needs of people most at risk for poor outcomes in time to make a lifelong difference requires sustainable funding for CSC teams serving the entire state. Providing proper care for Maine's most vulnerable youth requires LD 674. I am grateful for the many young people and families that have graduated from our program and continue to be involved through our advisory, through advocacy, and sharing their stories. These are the people who inspire us. Please listen to them. Please support LD 674 so that we can expand these services to more deserving young people throughout the state. Thank you very much. And I'm happy to answer any questions.
Thank you. Questions for Ms. Lynch? Seeing none. Sarah, did you submit written testimony into the portal?
I did. I signed up before I attached the written, but I think the written was attached this morning.
I'm not seeing it.
Do it.
So
Okay,
maybe you can try it again.
Okay, I'll try it again. Sorry about that. I'll make sure.
That's quite all right. Thank you for being here. Senator Claxton, do you have a question for Ms. Lynch?
Looks like we've updated our testimony list a lot this morning. So we now have some of the testimony we were looking for earlier, and I think Ms. Lynch's is included in that list now.
Okay, thank you very much.
Thank you.
We do have testimony from Jan Collins.
Thank you so much, Senator Claxton, Representative Meyer, and honorable members of the Health and Human Services Committee. My name is Jan Collins, and I'm Assistant Director for Maine Prisoner Advocacy Coalition. I'm here today to speak in support of LD 674, an act to support early intervention and treatment in psychotic disorders. I'm having a little difficulty talking because as I listened to the testimony before me, which I'm very, very grateful for, I realized I was hearing the happy endings. With my work with Maine Prison Advocacy Coalition, I hear from the not so happy endings. I hear from parents whose sons have died because they committed suicide in jail. I hear from mothers whose sons attempted suicide, survived, but are no better off and are cutting themselves. And some of whom are being removed, several of whom are being removed to hospitals for blood transfusions as a result of their self-inflicted injuries. I hear regularly from parents or sisters or brothers or friends whose loved ones are in jails where they are not receiving their medications for their mental illness and are suggesting that they will not survive their stay in the jails. The solutions to this issue are well known. Education, destigmatization, expanded services and supports, housing, and fair remuneration for those services. The answers are not new. We know and have known how to care for people and families struggling with mental health. What has been missing is the political will and the purse strings that are necessary to make it happen. Members of this committee know that better than anyone. Let this be the year that we make dreams come true for those who are struggling with mental health. Those who have felt left alone, afraid, and unheard. Please, not only pass this bill, please fund it. Thank you.
Thank you, Ms. Collins. Questions for Jan Collins? Seeing none, I'm glad you were here today to share your perspective.
Thank you.
Appreciate that. We have no other signups for testimony, so I would ask the committee if they have requests for additional information for the work session. Yes, Representative Perry.
I think I'm just going to reiterate the information that was offered to us early. I want to make sure that we get that in plenty of time before we work it, so we have time to go over it.
Seeing no other hands up, I would close the public hearing on LD 674. Turn to our analyst to see if there is anything else on our agenda before we break for lunch.
Not that I'm aware of.
Okay. And it's 11:45. We'll see everyone back here for work sessions at 1 o'clock this afternoon, and the committee Democrats at 12:15. Have a nice lunch.
Everybody have a nice relaxed lunch. Fastest peanut butter and jelly sandwich I ever made and consumed while I was on 2 meetings.
That's what I had too.
I've got a plan better than this. Looks like we're back at quorum. We may have some other people joining us as we proceed. So this is the afternoon session, a work session for the Joint Standing Committee on Health and Human Services. We'll be reviewing a total of 5 bills today, and then seeing if anybody wants to review a report as we proceed. Is there anything else on the agenda I should know about as I look to our analysts? So we're ready to proceed. We'll just do them in the order in which they're published. Let's start with LD 330.
Okay, I'm going to share my screen. See if I can pull up the right thing. Okay, hopefully you can all see that. Okay, I can see Senator Moore nodding at me, so that's good. Okay, she's right, the one that's right in the middle for me. So LD 330 is an act to prevent accidental overdoses by establishing a protocol for prescription drug recovery. This bill seeks to reduce accidental overdose deaths caused by access to unused controlled substances. It requires an agency, facility, or individual who offers or plans to offer any in-home or community support services or institutional services, and who administers a controlled substance to an adult with long-term care needs as part of those services, referred to in this bill as an administering provider, to document any controlled substance prescribed and obtained for an adult with long-term care needs. And those folks are referred to as client patients in this bill, and to participate in the PMP. The bill also requires all controlled substances to be kept in a locked container to which only the administering provider, the patient, and if there is one, a designated caregiver, have access. And it requires the administering provider, upon the death of the patient, to collect any unused controlled substances that were prescribed for that person and dispose of them properly after documenting the National Drug Code quantity and strength. The administering provider is required to submit this documentation, including the manner of disposal of the controlled substance collected from the deceased patient, to the department using the reporting system in the PMP. So you heard from the testimony that the sponsor is looking for a method to track and dispose medications after the person that the medications were prescribed to has died. You heard concerns from the opponents about intrusiveness of nurses visiting after death, and also the possibility of making them targets. You heard that processes already exist to manage controlled substances, that lockboxes, which are already used, sometimes particularly with children, could result in lost keys and some confusion, and medications are the property of the patient and in their home, and that list of medications and plans of care are already sent to the homes, and families are asked to dispose of medications after death. You heard about a need for continuing education on that medication management and disposal that would be required in every patient's home, and increasing the use of the prescription disposal. You heard from the department about the PMP, that it's structured for clinicians and pharmacists, and this would require a completely new user role, and that would allow some unlicensed home and community support workers to get into the PMP, and that also results in a fiscal note for related to HIPAA compliance and PMP training. They offered an alternative as a fillable form on the PMP or Office of Behavioural Health website. They also heard concerns from them about the lockbox and the need to define client-patient locations to avoid conflict with existing long-term care settings in those regulations. So there are some drafting issues in here. The PMP is checked by prescribers and dispensers, and it's not entirely clear why establishing a new class of user is necessary for disposal, and what that would also mean if for the administering provider that is providing that information to the PMP when they're working in somebody's home. This proposed section in this bill applies to an adult with long-term care needs, which is much broader than hospice. It applies, the way it's written, it applies to institutional and any home and community-based care and other direct care workers that are qualified to administer medications. And I haven't seen the term client patient before. Maybe it doesn't matter, but I haven't seen that term used in the statute. And whether there should be some sort of different process for institutions and home care. I think the conversation during the public hearing really concentrated on hospice, but this is actually written to be much broader, and I don't know what the impact would be on nursing facilities and hospices that are in institutions. The administering provider is defined to include an employee or contractor of a provider. And so subsection 5, or the proposed subsection 5, requires each administering provider to develop a written policy. And I don't know whether that's for each person, each patient, or whether that's the employer. So there are some things to sort out there if you want to move forward. You did ask for some additional information. We asked the department, DLC in particular, since they license hospice agencies, both at home and institutional, what their policies are on medication. And I asked them whether there were some standard or typical policies around the following. So where is that memo? Try email that I received. I don't know right now. We asked about providing healthcare plans and medication lists to families at home. We also asked about providing information about disposal of medications included after the death of a patient at home, and I'll go down to the rules in a minute to talk about that. Whether there's a standard form that family members have to sign about medications and disposal at home, and there isn't a standard form. Hospices are free to use or develop their own processes. And then whether there are requirements around disposal of medications after the death of a patient. So I'm going to skip down a little bit further to these rules, these federal rules, and you can see in terms of the home, this 2I guess it is, this is the part that relates to the patient's home, and the hospice has to have written policies and procedures for the management and disposal of controlled drugs in the patient's home. And you can see they have to provide a copy of the hospice policies to the patient and the family, discuss the hospice policies and procedures for managing the safe use and disposal of controlled drugs, and documenting in the patient's clinical record that the written policies and procedures for the managing controlled drugs was provided and discussed. But it's not a standard form, but it is a federal requirement. And then you can see there with, I guess that's 2 really, not I, that this is the part that relates to inpatient, and the hospice that is providing the care in their facility must dispose of controlled drugs in compliance with the hospice policy and in accordance with state and federal requirements, and the hospice must maintain current and accurate records of the receipt and disposition of all controlled drugs. Bill Monteo also said that, actually I assume it was Bill, I guess we'll have to say Molly, that hospice agencies must coordinate and address this through a written agreement with any nursing facility in which the hospice agency is providing care within. So I'm going to go back up again. There are DEA rules, and you heard about these during the public hearing, that were clarified to state that hospices were prohibited from disposing or assisting in the disposal of controlled substances for hospice patients unless there is a state law granting authority to do so, and that the rules do actually encourage education. There was a law passed in 2018 that includes, as part of that, the Safe Disposal of Unused Medication Act. And this act allowed but does not require certain home hospice staff in qualified hospices to dispose of controlled substances as long as it was lawfully dispensed and destroyed on site. That qualified staff are physicians, PAs, and nurses, not all staff. And apparently there's no effective date or guidance on that law yet. And there was also a GAO study, which I sent to you about that if you were interested. And then there's those federal rules. There is a bill. I got an email from Representative Hymanson at some point during this bill related to LD8. She wanted you to know that there is also a bill in ENR that requires certain drug manufacturers to operate drug take-back programs. I believe you heard from Senator Gratwick this morning. That was one of his babies. That bill is still in committee, although it has been voted 10-3 ought to pass, requiring certain drug manufacturers to operate take-back programs. You also had questions about other states. I did reach out to NCSL and got an enormous number of bills from them, laws from them. The only ones I could find that were related to hospice were New Jersey, Pennsylvania, and Maryland that have laws that allow hospice providers to dispose of unused medications, but the law also requires surrender of the medications. And despite what it says there, I sent you the Maryland law, not the Pennsylvania law, and the New Jersey law was below what I sent you yesterday. There are a number of other states who have drug take-back laws similar to LD8, and I didn't tally up all of those. And OFPR preliminary fiscal impact statement, you also heard about this from the testimony from OBH, that the department will require a general fund appropriation of $105,000 and then $30,000 ongoing, and $75,000 is the one-time technology upgrades, and then $30,000 in ongoing costs.
Are there any questions for Anna of that analysis? Yes, Representative Cardigan. Madigan.
But we know she can make cardigans. She's a very good knitter.
I could. I just want to know what the, you said there were laws about surrender of medications in other states?
It's the three states that have laws about hospice providers being able to dispose of unused medication prescriptions. They also require the surrender of the medications by the family. In other words, they aren't going in and taking the drugs in the way that is anticipated in this bill.
Okay, that's what I want to know. Thank you.
Any other questions for Anna? Before we get to further discussion, Senator Moore has chastised me gently for not doing introductions. So why don't we go ahead and do that now? And we can go around the horseshoe, starting with Representative Griffin. Yes.
Good afternoon. My name is Abigail Griffin. I represent House District 102, which is Glenburn, Levant, and Kudeske.
Representative Connor has joined us.
Thank you, Mr. Chair. Good afternoon, everyone. My name is John Connor, and I proudly represent House District 58, which is part of Lewiston.
Representative Craven.
Thank you, Mr. Chair. I'm Margaret Craven, and I represent House District 59, which is part of Lewiston.
Representative Madigan.
Hi, I'm Colleen Madigan. I represent House District 110, which is part of Waterville and part of Oakland.
Representative Zager.
Hey, Mr. Chair, Sam Zager, District 41, Portland.
Representative Lemlin.
Good afternoon. I'm Michael Lemlin. I represent District 88, Chelsea, Jefferson, Whitefield, and half of Noblesboro.
Representative Stover.
Good afternoon. My name is Holly Stover. I represent House District 89.
And Senator Baldacci.
Good afternoon. I'm Joe Baldacci. I represent Senate District 9, which is the city of Bangor and the town of Herman. Thank you.
Representative Perry.
Good afternoon. I'm Representative Ann Perry. I represent House District 140, which includes Indian Township, Beattyville, Bering, Calais, Charlotte, Robinson, Perry, Pembroke, and Pleasant Point.
Representative Jabner.
Good afternoon. I'm Representative Kathy Jabner, and I represent House District 141, which is located in Penobscot and Washington County.
Senator Moore.
Thank you. Good afternoon. I'm Marianne Moore, and I represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, and Sullivan in Hancock County as well.
Representative Meyer.
Good afternoon. I am Representative Michelle Meyer, serving Southern Maine's House District 2, which is all of Elliott and parts of Kittery and South Berwick.
And I'm Ned Claxton, and I represent Senate District 20, which is Auburn, Minot, Mechanic Falls, Poland, and New Gloucester. So we proceed, we'll continue with discussion of LD 330. Are there comments questions. We have some people with some expertise in who have joined us who could address any questions we have, or we can go directly to them. What's your preference? Yes, Representative Zager.
Thank you, Mr. Chair. It occurs to me that there's really a lot of detail in this and different ways that this particular issue could be dealt with. I'm not entirely sure that it needs legislation to achieve what I think a lot of people would want, which is to reduce the risk of opiate overdoses. I would move that we table this to permit the sponsor of the bill and other stakeholders to have a little bit more opportunity to work out some of the details and figure out a way forward that people can agree to.
So there's been a move to table and a move to second. So why don't we ask Ms. Withy to officially do a vote?
Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover. Representative Stover.
Sorry, yes.
Thank you. Representative Stover, yes. Senator Baldacci.
Yes.
Senator Baldacci, yes. Representative Perry.
Yes.
Representative Perry, yes. Representative Griffin.
Yes.
Representative Griffin, yes. Representative Connor.
Yes.
Representative Connor, yes. Representative Craven.
Yes.
Representative Craven, yes. Representative Madigan.
Yes.
Representative Madigan, yes. Representative Javner.
Yes.
Representative Javner, yes. Senator Moore.
Yes.
Senator Moore, yes. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes. That's 13 yes.
So we'll be coming back to discussion of 3:30 at some point in the future. I do feel obliged to point out that there are a couple of other bills, one that's already been heard and one that's still in revisor's office. I think we also generally and clearly acknowledge that we need to do something upstream of the opioid overdoses. And we just want to make sure it's a coherent whole in response. So we appreciate this bill having been brought forward and prompting some more conversation about a really important key topic. So thank you for that. And we'll have a chance to revisit it. That'll bring us to LD 396.
Okay. LD 396. So this is an act to require the Department of Health and Human Services to provide assistance with applications for basic necessities to prevent children being removed from parental custody. Section 1 of the bill, so Title 22, Section 4003, subsection 2 of the Child and Family Services and Child Protection Act provides that children will be removed from the custody of their parents only when failure to do so would jeopardize their health or welfare. This bill enacts a subsection 2A that stipulates that children will not be removed if that jeopardy is evidenced only by deprivation of economic necessities due to insufficient income and resources. For Section 2, current law in Section 4004, subsection 2, outlines the duties of the department. That includes, after an investigation, the department, when the department does not file a petition but does open a caseworker shall provide information about rehabilitation and other services to assist the family. This bill amends that subparagraph to include applications for aid programs that provide basic necessities. So you heard that the sponsor's purpose is to make clear that poverty can't be the reason why a child is removed, and that the concern that most children are removed for neglect and want to ensure that that neglect is not economic. The department is opposed. They said there was no data to support the idea that children are being removed for economic circumstances, that this would be a new responsibility for OCFS staff. This is the part about providing helping with applications. The removals don't happen without a court order, and a court wouldn't find that the department had made reasonable efforts if the department hadn't tried to connect families with programs. He also said that a small subset of parents who refuse to participate in programs, and this would limit the options with those families. And they're also concerned about discouraging mandated reporters. You heard some issues about shelter, homelessness, or stable housing raised on both sides. Shelter residents are cited as reasons for child protection cases as well as orders for removal, and that requirements for, that's supposed to say stable housing, not stale housing, I'm sorry, for reunification is harder than it looks. On the other side, you heard some concerns about creating a mandatory loophole to prevent, how many typos can we find today? To prevent unaccompanied youth and children from being placed in care. You heard from Mid-Maine Homeless Shelter and Services. They requested an amendment to reference abandonment. So no, in other words, adding to the no reasons besides poverty, and no evidence of the conditions of abandonment. And I glad, which I could come up with what that stands for, also suggested including private sources of assistance in order to the state and federal aid or medical programs. So just some drafting notes more so than issues. Section 2 for the existing section 4004 subsection 1 is the section with a general authorization for the department to take appropriate action to prevent child abuse and neglect. That includes services that support parental care, supplement parental care, and substitute when necessary. In other words, step in. Also encouraging the use of services, cooperating and coordinating with other agencies providing related services. Subsection 2 requires the department to act to protect abused and neglected children and those at risk. Paragraph E is specific to after an investigation, but not a petition, assigning a caseworker who provides information about services and developing a child and family plan. It's not entirely clear that subsection 1 doesn't overlap with section 2 of the bill. In other words, what's currently in existing law for subsection 1 might overlap with the new subsection 2, the new section 2 in the bill, or perhaps whether subsection 2 paragraph E is the right place to put that requirement. So I'm not entirely sure that things are put in the right place here. You also asked for cross-references and requests for additional definitions. So some of them were, I think these were already online, but you obviously can't look in two places. Well, you can, but I can't. So abuse or neglect is currently in the definition section, and you can see there on this second line of the definition that it includes deprivation of essential needs. And then abandonment is there because of the request to include abandonment from the homelessness advocates. And then the other section that is a definition that is related is the jeopardy to health or welfare or jeopardy. And you can see there on paragraph B, deprivation. And so if you were looking at the law, you can see that, I mean, looking at the bill rather, that the way it is drafted is to ensure that children will not be removed from the custody of their parents by the department if the jeopardy, and you can see the jeopardy there, to health or welfare is evidenced only by deprivation of adequate food, shelter, and you can see that that crosses over to the definitions of deprivation and jeopardy in the current law. So you also requested some information from the department about homeless vouchers specific for families in an active child welfare case, and homelessness. You wanted some information on homelessness and also how to improve the visitation issue, that there are a lack of services for supervised visitation issues. And you also asked for the number of children in custody and statistics about placement of children with other families. You received that memo kind of last thing this morning. So I know that Dr. Landry is here. I mean, I could read it to you. I could also bring it up on the screen, but it's up to you how you want to go about doing that. I do know that Dr. Landry is here, and I can also bring, as is Molly, and I can also bring up the memo on screen if that's helpful.
Let's start with questions or comments. Senator Baldacci.
Thank you, Mr. Chairman. I would actually move ought not to pass on this bill. I think I raised some issues before, and I totally agree with the sponsors' aspirations and objectives, but having dealt in family court and child protective court and the assorted custody related court matters for a long time, I see, unfortunately, a really huge unintended consequences with that language, which is actually going to make appropriate cases more difficult to happen. It's going to I just see it as a lawyer's, and I hate to use this term as a lawyer, but a lawyer's paradise of litigation, because we can take a lawyer who is representing a parent in that case it's going to create a lot of problems that take the focus away from the child, in my opinion.
Okay.
And I think it needs to be better thought out overall. So I move ought not to pass.
Representative Javner, you had your hand up?
Yes, thank you very much, Senator Claxton. Before we get a second on that motion, can we please hear from Dr. Landry concerning these specific issues so that we can have the answers to how the department is going to address these issues? Is that possible?
Sure. Yeah. Yes. So if we'll, Dr. Landry has joined us. If you'd like to speak up, sir. Thank you.
Yes, good afternoon. Thank you for having me. We were happy to be able to provide some additional information to you via memo, and my apologies that came to you just this morning, but hopefully you've had a chance to review that information at least in a short or a quick format. What I would simply point out is on a couple of the specific questions that we were asked on this topic, we did provide you with some information on housing vouchers that are specific to families and child welfare cases and who may be experiencing homelessness. So that information was provided to you. I can tell you, I believe the total number of those vouchers is 115. So we have 115 of those vouchers in partnership with Maine Housing. And those have recently just been increased slightly, we believe, with some of the federal relief funding that's come through to Maine Housing. So that's one of those key areas. If one of those vouchers is not available, we certainly work with families about other housing options that are available to them, including the ETV or I believe if I got those initials right, that program as well. I believe there was also a question about children in custody and statistics about placements of children with other family members. So we've issued you some data to show you where those trend lines have been. I believe this was to a question by Senator Baldacci. And so as you can see there, the data that we have on number of children in our custody or in the state's custody in place with relatives has steadily increased from 2008 to the current. That mirrors very much a general trend across the entire country. So I want to point that out. I do believe Maine has always been on slightly above the national averages as far as the percentage of children in the care and custody of the state placed in relative caregivers' homes and families. And that continues to this day. And so those last data points would indicate currently we're right at 43% of children in our care and custody placed with relatives. And that compares, about 10% more than the last data we have on a national average basis. So that's some of the information that was requested. I believe we also did provide with you with some statutory references as it relates to placement of children into relative caregiver situations. Happy to answer some more questions that you have on that, but I know we also have a bill related to kinship navigators that we'll be talking about later this afternoon as well. So you may want to hold those questions, but we address them in this bill and in our response regarding this bill, because that's where the original question came from, I believe, Senator Baldacci.
Did you have follow-up questions, Representative Jadner?
No, I do not, Senator Claxton. Thank you, Dr. Landry, very much. I appreciate that information greatly.
Does anybody have questions about that information from Dr. Landry? I don't see any. I do also see that the sponsor is here. Representative Brennan, you've heard some of the questions, concerns, and follow-up information. Any comments?
And thank you, Senator Claxton and Representative Meyer, and members of the committee. In anticipation of some of the questions from Senator Baldacci, I just want to provide a couple of brief points to this discussion. In additional research, what I found is that there are at least 50 states in the country that give a specific exemption in their child welfare statute to poverty. And there are 6 states, Arkansas, Kentucky, Minnesota, Nebraska, and North Carolina, 5 states that have specific statutes that prevent poverty from being a factor in taking a child into the child welfare system. So the overwhelming majority of states in the country address this issue with a specific exemption, and there are 5 states that have a specific statute. And I did go to the American Bar Association, and there was a lengthy argument, not lengthy article about any number of court cases related to this particular issue and defining poverty and neglect. And I certainly am not in a position to argue any of those with Senator Baldacci, but it clearly has been something that's been litigated, and there have been a number of court cases relative to it. So earlier this week, I did have an opportunity to speak with Molly Bogarts, and I suggested if they were still not willing to support a statute, that we at least get a clear policy statement from the department saying that poverty was not a deciding ise in taking somebody into the child welfare system. And at this point, I haven't gotten any definitive response. So I do understand the motion ought not to pass, but at the same time, I do think as a state, we should somewhere, whether it's in statute or in policy, make a definitive statement about the fact that we understand the difference between poverty and neglect, and that we are not unnecessarily or inappropriately bringing children into the child welfare system simply because their families do not have financial resources. So thank you very much. And I, again, appreciate the thought and the time that the committee has put into this issue. And if it does not prevail today, I will certainly look at a time to work with you in the future on how we might be able to continue to address the issue.
Dr. Landry, did you have any thoughts about a policy statement or suggestions for how?
Yeah, happy to address that. And we're happy to share with you the specific, and I'm reading it here on screen, specific intake policy. So specific policy to our staff, and then we train to this policy, of course. The specific definition of neglect: failure or refusal of a caregiver to assume responsibility for a child's basic needs for reasons other than poverty, including caregiver failure to protect the child. So I believe our policy very clearly states that. We train to that policy. We carefully train our staff to understand the underlying conditions of poverty versus neglect. We also recognize and understand that it is the way that we implement that policy is for the sole reason of poverty. You know, clearly, if there are other reasons, and poverty is a reason there, but if it's the sole reason, that's where this policy really comes into effect. We recognize that in almost all cases of department involvement, where the child, where we file for a PPO or jeopardy, very rarely is it ever just one situation or one circumstance. I think we all recognize there are usually multiple circumstances involved, but I believe our policy is quite clear right now that it very clearly specifies for reasons other than poverty.
Thank you for that. Senator Baldacci?
Thank you. I want to commend Representative Brennan. I totally agree. I was the thrust of what you're saying and how it should be done, and I would be okay with the policy statement. I just think if we enshrine this as a statute, I've been doing, I've practiced law for 30 years. I've done thousands of child custody cases. I've done thousands of DHHS cases. I've even sued the department a couple of times. So I'm not sitting here saying, everything's hunky dory, but I could see this being I could see it being misused. I could see it being distracting the court or the system from the basic issues of protecting the child. So I have no problem with some sort of general policy statement. My experience is that judges are very sensitive on this issue and will listen and are going to differentiate. So I don't have any disagreement with your objectives. I have concerns about it becoming a statute.
Dr. Landry?
Go. Thank you.
Yeah, thank you for that, and thank you for the opportunity to speak again. I would simply also reiterate that that the department never is able to implement a PPO or jeopardy without court involvement. And one of the specific requirements of the court is to ensure that those reasonable efforts have been met and that we have achieved or surpassed those reasonable efforts before they can, in fact, grant the PPO or the jeopardy order. So I did want to mention that. I know we've talked about it in the hearing, but I wanted to reiterate that piece as well.
Thank you. So there is a motion on the floor.
I'll second.
There and a second? Is there further discussion of LD 396? Not seeing any, then I defer to Ms. Withy for the roll.
Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci.
Yes.
Senator Baldacci, yes. Representative Perry.
Yes.
Representative Perry, yes. Representative Griffin.
Yes.
Representative Griffin, yes. Representative Connor.
Yes.
Representative Connor, yes. Representative Craven.
Yes.
Representative Craven, yes. Representative Madigan.
Yes.
Representative Madigan, yes. Representative Javner.
Yes.
Representative Javner, yes. Senator Moore.
Yes.
Senator Moore, yes. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes. That's 13 yes.
Thank you for that. And Representative Brennan, I think I can speak for the committee. We've learned a bunch in this process, and I think we understand elements of this work in a way we didn't before. I think we'll be watching and listening for any occurrence or episodes that might deserve more attention in some way or another. So we're grateful to you for that.
Well, thank you, Senator Claxton, and I appreciate again the attention that the committee gave to this issue, and I'm glad that it is now something that we can pay attention to and continue to work with the department to make sure that that policy is acted upon in a meaningful way. So thank you very much.
Thank you, sir. So that'll get us to working on LD 510.
All right, well, we have another changing of the guard here, so I will be with you for the rest of the afternoon. Just going to share my screen. Hopefully you can see my bill analysis on
we can.
510. Okay. LD 510 is resolved to reduce stigma regarding substance use disorder by requiring the use of respectful language in the Main Care Benefits Manual and other DHHS publications. It directs DHHS to replace references to substance use with substance use disorder and apply person-first language throughout the main care benefits manual and other department publications. A couple of years ago, the legislature enacted Public Law 2017, Chapter 407, which was the result of LD 1871 in the 128th that went through all of the statutes, really. I thankfully was not the one that had to go through that. Somebody else in my office did, to identify statutory places to amend it to be substance use disorder and replace language that was not respectful and change it to person first language. So that that bill also included this directive to executive branch agencies relating to rules, publishing forms, policies, and publications that you can see here on the left. There is a question about what the difference is between that enacted law and the current bill before you. That one is broadly, the existing law is broadly applicable to all executive branch agencies, while LD 510 is focused on DHHS. And the enacted law is about rules or forms, policies, and publications generally. And this LD 510 is about specifically the main care benefits manual and other department publications. You requested information from the department about what sections of main care have already been updated to reflect person first language. And what sections were left to update. The department provided a policy master list that you should have received last evening with details about the different sections of policy under the benefits manual. There are 21 that need to be fixed and 7 are in process. The department also notes that none of the proposed changes have been finally adopted and that further amendment would be needed to section 65. But due to an oversight, a few references remained and would need to be amended soon. You also had questions about the applicability of the Maine Administrative Procedure Act and the legislature's ability in amending that act with regard to directing the department to update its rules under the Main Care Benefits Manual. So I've linked back here to Anna's presentation, to the rulemaking presentation she gave at the beginning of session. Generally, the Maine Administrative Procedures Act provides for public notice and an opportunity for comment, either with a written comment period or a public hearing as part of the rulemaking process. And there are different timelines that would be provided in the Administrative Procedure Act for the department to engage in that rulemaking process. When we did the bill in the 128th, that bill was drafted, I think, as a committee bill, and then it received a public hearing. And there were some places where participants noted that changing a statute in a particular way might have a potential impact to federal compliance and funding. I'm unable to determine whether changing the rules would similarly potentially have an impact on federal compliance and funding, but that would be something that could be revealed during a public comment period during the Maine Administrative Procedure Act. And I mentioned that because the legislature's authority is very, very broad. And so if you wanted to, notwithstand the Maine Administrative Procedure Act, or change timelines under that act, or otherwise tweak with the standard rulemaking process, you certainly have the ability to do that if you want. But the legislature's authority is limited by the Constitution, and if there are changes that are made to the rules that are not just ministerial or technical changes, but actually have a substantive impact on compliance and funding to benefits that somebody would actually receive, you might be bumping against a due process issue. The preliminary fiscal impact statement shows one-time costs of a little over $1,000 in general fund and $4,200 in federal expenditures for technology changes, and a fiscal note would be required to this bill as drafted.
So are there questions for Aaron? I'm a little puzzled by the fiscal note because it sounds in some ways that the work has already started and ongoing. Why would we necessarily incur additional expenses unless they're, is it related to a timeline?
I did ask Luke for that information. I'm going to have to pull up his email to see what the department provided, but I know I think Molly Bogart is here too.
Well, maybe Molly, we should go to Molly because her hand is up while you do your poking it
All
out.
right, so I can read Luke's email to you when you're ready.
Okay. Molly, did you want to join us? Oh, Ms. Bogart, there you are.
Good
Welcome.
afternoon. I'm Molly Bogart, Director of Government Relations for the Department of Health and Human Services. My understanding of the fiscal impact from Maine Care is that in order to not disrupt other rulemaking that we are currently doing by prioritizing these 21 sections, or I should say 14 sections that are not currently underway, we would need additional staff time to make sure that all of the current plans, which include program changes, rate changes, et cetera, are not delayed. If we were to prioritize this change, which this bill would ask us to do.
And do you have a timeline for accomplishing what's currently in statute?
I don't think that we have an explicit timeline, but
okay.
as rules are opened, we are looking to make those amendments.
Okay. Are there other questions of Molly? Did you find that note from Luke Lazar, and is that consistent with what he's written there?
So this is based on the information Luke received for the preliminary fiscal impact statement. He says, I do not know the specific changes that will be made, but the technology changes are in the claim system for Maine Care. I would guess that if they change names in all sections of policy at once, they would need to make corresponding changes in the claim system to match the new names of codes and policy sections. The department did not include any information on rulemaking in the fiscal impact in the fiscal estimate they sent to us.
Okay, thank you. Are there any other questions for right now before we ask the committee sponsor to join us? And you've heard some of the questions and concerns. Any feedback, comments? Welcome.
Thank you. Thank you, Senator. I want to thank your analyst, Aaron, for talking me through some of the questions that came up at the public hearing. I'd like to point out that as in the earlier bill referenced, the intent is not to change anything that would impact federal grants or funding. I also would say that my focus in the first bill was the recommendation of the opioid task force, and I was focused on statutory changes. This bill, I was requested to put this one in by practicing practitioners who were finding that the manual was full of references that are disrespectful. And going through a part that has been adapted, it was clear that it wasn't fully, there were a lot of things left in that I shared with the committee, and that was explained as an oversight, which I appreciate. So I think if we're going to make changes in people in recovery, people getting into recovery, we need to be very mindful of the language that we use in personal interactions and in our literature. So that's the impetus for the bill. the intent is not to lose any federal dollars for sure, but to just be sure that we're being respectful and helping people as opposed to pushing them down.
Okay. Very good. Any comments, concerns, questions out there at this point? So let me ask, yes, for Senator Moore.
Thank you, Senator Claxton. I feel like the department is doing their best to update as they go along, and everything that they touch, they are making it a point to be respectful and change that titling. So in view of that, I think we should let them continue on with their work instead of forcing something else on them. So I would make a motion ought not to pass.
Would you accept a friendly amendment of a regular report back on progress on the 21 sections?
That would be good. I would, yes, that sounds like a great idea.
Thank you.
I would
Thank
second
you.
that.
So we'll count Senator Moore's as the motion and a friendly amendment that's been accepted. So it's any other comments? Yes. Aaron.
Are you looking for that report back to be in unallocated language as part of this bill, or are you looking for a letter?
I'm open to suggestions. Representative Meyer, do you have a feeling strongly one way or the other?
If this is the way we're going to go, I would like to see this in a letter that impresses upon the department that this is of concern to us, that we would like to see this work completed in a manner that's practicable, and that and include that we'd like to see a report back in 22 as to their progress.
Early 22. Okay. All right. Any other thoughts, comments? So the motion on the, yes, Representative Javner, I see you reaching for your button.
Thank you very much, Senator Claxton. Yes, and I just want clarification on what the motion actually is. If we're going to vote ought not to pass, but yet we're having an amendment on it, are we not having an amendment anymore? Is it just a letter?
Oh, you're so fussy. So it's Senator Moore's motion, which was ought not to pass. We can then come back and reconsider the request for a letter when we get done voting on the ought not to pass. How about that? And so there's no friendly amendment, but there it was a second, as I understand. Yeah. Okay. So the motion has been ought not to pass, has been seconded. So we'll ask Ms. Withy to run the vote. Thank you for help, Jana. Representative Javner.
Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci.
Yes.
Senator Baldacci, yes. Representative Perry.
Yes.
Representative Perry, yes. Representative Griffin.
Yes.
Representative Griffin, yes. Representative Connor.
Yes.
Representative Connor, yes. Representative Craven.
Yes.
Representative Craven, yes. Representative Madigan.
Yes.
Representative Madigan, yes. Representative Javner.
Yes.
Representative Javner, yes. Senator Moore.
Yes.
Senator Moore, yes. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes. That's 13 yes.
Okay, and I'd also entertain a motion to request a letter from the department, a report early in 2022 to see if we need to resurrect this piece of legislation for
Make
lack
that
of
motion.
progress and additional support.
I'll make that motion.
Thank you
Second.
for that. And there's a second for that. Is there any further conversation about that? Yes, Representative McCray. Please.
Thank you. Thanks for letting me speak. Clarification, like Representative Javner, are you thinking to, I mean, you just did ought not to pass, so I think my question is moot, but are you talking about carrying it over so that it can be resurrected, or are you thinking you would report something out?
I think we would report something out, is the way I understand it, that will assess what we learn in January and see if we're making enough progress. And then we already have somebody who's drafted a bill for us if we need one to encourage further good behaviors.
Thank you. I appreciate you getting the report back because it's been several years and it's not done.
Well, and you've raised a important issue, and I think as a group we support that. We just want to do what we can to move it along. So thank you.
Thanks.
All right. So there's a motion to send said letter to the department for said report. Any other discussion? It's been moved and seconded. So now we'll ask Ms. Withy to vote on that, register the vote on that.
Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci.
Yes.
Senator Baldacci, yes. Representative Perry.
Yes.
Representative Perry, yes. Representative Griffin.
Yes.
Representative Griffin, yes. Representative Connor.
Yes.
Representative Connor, yes. Representative Craven.
Yes.
Representative Craven, yes. Representative Madigan.
Yes.
Representative Madigan, yes. Representative Javner.
Yes.
Representative Javner, yes. Senator Moore.
Yes.
Senator Moore, yes. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes. That's 13 yes.
Very good. All right. So now we'll move to LD 590. And Representative Lemlin's bill, and hear from our analyst.
Okay. LD, hopefully you're seeing my screen.
We
not
are.
my email. Okay. LD 590 is an act to require main care coverage for ostomy equipment. It requires main care to reimburse for equipment and supplies for ostomy without prior authorization or limitation when it's recommended or prescribed by a physician, and provides that the reimbursement rate must be no less than the cost of the equipment. And it directs DHHS to implement those rules no later than January 1st, 2022. You heard from the Maine Nurse Practitioner Association recommending an amendment to include all health providers who would order ostomy supplies, including nurse practitioners and PAs. You had some information requested of the department about what the dollar amount is of 85% of the 2011 Medicare rate. The department provided an Excel spreadsheet with all of the different ostomy related codes and the associated rate that you should have received last night. And then you also asked, what is the cost of the 90 days of ostomy supplies? And the department said it wasn't able to determine that, and it would have to come from suppliers of those products. The fiscal impact on this bill is not yet determined. In trying to make sense of the experiences of members of the public who testified at the public hearing and trying to understand what current practice is, I reached out to Molly, and I'm grateful that her and Main Care were able to provide me with some additional information relating to some of the experience described and then how the process works within the Main Care program. And then I noted on the side here kind of how the LD overlays with some of those experiences and processes. So I can go over that in more detail if you're interested. But before I do that, I just wanted to also note a couple of other information for you. During the budget, if you recall, there was a discussion about upper payment limit in regard to durable medical DME. I can't remember what the E is right now, to DME, but ostomy supplies are not included in the DME for the upper payment limit. So we would not be presented with a UPL issue in relation to this bill. And then Main Care also directed me to the Main Care Benefits Manual relating to the limitations on the dispensing of disposable medical supplies and up to the 90-day supplies. And this is the source of the PA requirement that you heard about at the public hearing and that the bill is attempting to dispense with. So let me know how you'd like to proceed, if you want me to go through that chart or whether you'd like to do something else.
What is the will of the committee? Any questions? Yes, Senator Baldacci, you have a question or comment?
I think we were provided with 2021 rates. Is that correct? I'm trying to find or Molly, and probably we should, in terms of the cost issue, I mean, I think we should provide the 2021 rates, which I think would be a 30% increase over what's paid now. I think that would be a better way to provide a better incentive for this, because just saying, you know, an open-ended the cost would leave it open, you know, too much manipulation by private dealers. And I think we do need to increase this. So I would move ought to pass, but I'd move to amend the bill to include the 2021 rates as the method of increasing the reimbursement, which I think would be about a 25 to 30% increase. And it's up to the sponsor, but I would not be averse to including all healthcare providers. But my motion is just on increasing the reimbursement to tie it to the 2021 rates as the method of determining the cost of the supply.
And which rates are you referencing?
The
Medicare?
What's that, Mr. Chairman?
Which rates from what source? Main Care or Medicare? Because there aren't any Main Care rates.
So it'd be Medicare. Sorry.
Okay.
I think if Molly is she there, can she? If she's not there, Molly.
If she is. Molly's
is
here.
2021 Medicare rates. Is that what I should be referring to, or Main Care?
Medicare rates is what
Medicare rates. Yeah, I'm sorry.
Okay.
So it should be based on the 2021 Medicare rates, which would be a 30% increase in the reimbursements for these supplies. So that would be my motion.
Okay.
Seconded.
Is there a second there?
Second.
Yes. Okay. Erin, did you have a comment?
Right. So the current rate is 85% of the 2011 Medicare rate. What percentage of the 2021 Medicare rate are you looking for, Senator Baldacci?
I think if we leave it the 85%, but increase it to the 2021, it will result in approximately 30% increase in the reimbursement.
So 85% of the 2021 Medicare rate.
Right.
Okay.
Okay. I saw some other hands up. Have the questions been answered? Yeah. Okay. Good. All right. And as a friendly amendment, Senator Baldacci, would you accept expanding it to anybody who writes prescriptions for ostomy supplies?
That's fine. It's certainly a friendly amendment. I just wanted to make sure. I didn't know if there was any reason not to include them, so that's why I wasn't sure. So, but I'm happy to include them if that's what most people think is a good idea.
Senator Moore.
I was just wondering if we want to ask the sponsor if he's okay with what is being proposed as the amendment.
Okay, sure. Representative Lemelin, comment at this point.
Thank you, Senator. I'm in full agreement with the amendment, including all providers. And my only concern is I haven't seen the 2021 rates for Medicare. If they are 25 to 30%, then that would solve the problem, but I haven't seen them. So, you know, what you and I talked about was 100% of the Medicare. But if it goes up 25 to 30% with just going with the 21 rates, which I haven't seen, then I would be fine with that. But I haven't seen those rates.
And without those rates, we can't do the fiscal note. So that we won't see that until we come back for language review, right, Aaron? Okay. So,
but I do want to know that Molly's Excel spreadsheet, and I'm sure she could speak to this better than I can. Some of those rates are listed, but and there's a comparison here between the current rate by code and the 2021 Medicare rate. But if that's not correct, I hope she speaks up.
Molly, I just want to indicate that based on your analysis of the coding, I stated the figure of 25 to 30%. Is that consistent with what your review is from the spreadsheet?
That's consistent with my sort of quick mental math at looking at those comparisons. The 2021 rates are anywhere from 25 to 30% above the current rate. But it varies by rate. And so, you know, you have those rates and I encourage you to review them.
Thank you.
thank you. Senator Moore, is your hand still up? We'll put her hand down. Okay. Any other questions or concerns? So we'll be looking at the impact at the language review of the 85% figure. How much extra work would it be for to do the 100% of Medicare, as long as Luke's got his calculator out?
I'd have to ask him, but officially through the process, what gets processed is the amendment voted out of.
Okay. All right, let's start with 85% and see what he has to say. So there's a motion on the floor to adjust reimbursement rates for ostomy supplies. It's ought to pass as amended, the amendment being to move to 2021 rates from Medicare and to expand the list to include all prescribers for whom those services will be covered. Any questions before we vote? Yes, Representative Zager.
Thank you, Senator. There's also the question of the duration of the prior authorization. There are certainly conditions that are temporary, but in a great number of them, and I understand that the department, Medicare, main care might not have the resources to pay for things that are really short time limited. But I'm wondering if the sponsor might be amenable to an amendment to increase it from 90 days to 180 days or something along those lines.
How does that sound to you, Representative Lemelin, before we check with the person who made the motion?
Could you repeat that? I'm not fully understanding what you're asking.
Well, instead of the longest time that the prior authorization would be good for being 90 days, as it currently is, liberalizing that to 180 days to make it easier for people to obtain the supplies they need without requesting another prior authorization.
Right. Originally, the bill stated that no prior authorization was needed, but so I'm not sure why we'd have to change that. The 90 days was only on a 90-day supply that Molly mentioned. The main care only allows a 90-day supply at a time. Am I mistaken there, Molly?
No, so you're absolutely correct. The only situation in which there would be a prior authorization currently is if over 90 days of supply is requested.
Okay. So that's in the rules for Medicaid, for main care, right? That's not in statute.
Correct.
Okay. So we could request to extend it such that you could get a 180-day supply without a prior authorization.
Yeah, I, as a sponsor, as a motion,
yeah,
the maker of the motion, I would be fine with the 180 days. I do think we need to have some prior authorization standard just so that it's periodically checked, but I think it should be liberalized to at least to 180 days. I think Representative Zager's suggestion would make sense.
Does that make the drafting a challenge at all, Erin?
No, I can do that. I had just understood the bill that gets rid of prior authorizations altogether. So you'd be amending the language of the bill to provide that prior authorizations would be not to exceed every 180 days, or at a minimum every 180 days.
Yeah, not less than 180 days.
Yeah, Representative Perry?
Yeah, my question is, a prior authorization is required if you want to prescribe for a period greater than 90 days at a time. Am I correct? Which means I could prescribe 90-day supply every 3 months, and I don't need a prior authorization.
That's correct.
Okay, and as far as I'm concerned, that's fine. That's a lot of supplies. So it makes sense to just, leave it alone.
How does that, yes, Molly?
I would just note that if that change, it would require a rule change, which just requires staff time is something that we routinely do when bills are passed. But if there's some level of agnosticism about that timeline, then not requiring an additional rule change would certainly be welcomed by main care.
Well, just think of all the time you're going to save by not having to touch the prescription every 3 months. It's just instead of going to 6 months. But no, I'm just being facetious. So right now, can Medicaid dispense any medical supplies without a prescription or without a prior authorization?
So there are different prior authorization requirements across
exactly.
them. Yeah.
So this isn't, so to leave it where it is at 90 days is what's already established and in rules, and would be easier for the department.
And not in statute. And so when it's in statute, it's
yeah, no, I understand.
Less flexible in the future.
Yeah. Representative Zager.
Thank you, Mr. Chair. I suppose I'll withdraw my suggestion because it doesn't seem to be much of an issue. Just trying to make things easier for the whole system, but I withdraw that suggestion.
And I withdraw my willingness to be a friendly amendment.
Your friendly acceptance. So that gets us back to Representative Lemelin. Are you okay with leaving the 90-day prior authorization in place?
Yes, Senator, I am.
Okay. All right. So we've added and subtracted. We're back to the amendment that would move us to 85% of the Medicare rate and not changing the prior authorization.
For 2021, right?
To the 2021 rates.
Yeah.
So any other comments?
Include other prescribers. That was the other part of it.
That's right. Include other prescribers. Thank you. Too many moving parts. Thank you. So before anybody has anything else to say, we'll go to Ms. Withy.
Representative Zager.
Yes.
Representative Zager. Yes. Representative Lemlin.
Yes.
Representative Lemlin. Yes. Representative Stover,
Yes.
Representative Stover, yes. Senator Baldacci,
Yes.
Senator Baldacci, yes. Representative Perry,
Yes.
Representative Perry, yes. Representative Griffin,
Yes.
Representative Griffin, yes. Representative Connor,
Yes.
Representative Connor, yes. Representative Craven,
Yes.
Representative Craven, yes. Representative Madigan,
Yes.
Representative Madigan, yes. Representative Javner,
Yes.
Representative Javner, yes. Senator Moore,
Yes.
Senator Moore, yes. Representative Meyer,
Yes.
Representative Meyer, yes. Senator Claxton,
Yes.
Senator Claxton, yes. That's 13 yes.
Thank you. And does that represent your first passed bill, Representative Lemelin? I don't keep track of these things too closely, but congratulations.
Yes, it is. Thank you. And thank you all for your support. I appreciate it.
Well done. All right. So now we'll move on to 699 and hear from Aaron.
Okay. LD 699 is an act to create a kinship care navigator program within DHHS. It establishes within the department a program to provide resources and information to persons providing kinship care to children in the state, which is defined to mean the care of a child on a temporary or permanent basis by a person who is not the child's parent, but who is either a relative or a person who has a close relationship with the child, whether or not the department was involved in placing the child with the person. The bill requires the commissioner to designate one person to administer the program in order to identify and coordinate existing resources available to persons providing kinship care, develop collaborative working relationships with state agencies, social services agencies, and other organizations, and to provide referrals to available resources and information about obtaining services from DHHS. As a drafting question, I note that the term relative is not defined. I don't know if that's a road you want to go down. There's another definition of relative under the Child and Family Services and Child Protection Act that I've copied here. But the reason I ask is because it makes it sound like it's establishing eligibility to receive services under the Kinship Care Navigator program. And so whether it matters whether the person is a qualified relative or not, and that's your call. You received amendments from testimony to house the program outside of DHHS. You had also requested information from that GLAD be present at the work session, and I believe they have sent somebody here that you can call on. They also submitted a memo to the committee around lunchtime. And in that memo, I think they propose a suggested amendment that looks similar to a bill that was an amendment that was voted out of committee on a similar bill on the 128th, but all that information is in their memo that you should have. And like I said, somebody here is here to speak to that. You also requested the Kinship Advisory Board report. That information is attached to your email last night when we sent the bill analyses. And there were some other questions you submitted to the department about how the current contract works, information on kinship placement since 2008, and other information about the department's kinship plans. Molly Bogart sent that information shortly before lunchtime as well. And my understanding is that Dr. Landry is here to speak to that. The second question on kinship placement since 2008 was the answer is contained in the memo on LD 396 that you worked as one of the first two bills this afternoon. and the fiscal impact has not yet been determined.
Okay. Are there questions or comments related to the analysis? I don't see any. And is Anthony Lombardi here from GLAD? That's where that's where the letter came from, right?
That's correct.
Okay. So we'll have him. Welcome, Mr. Lombardi. So can you summarize the questions, concerns, suggestions from GLAD?
Of course. Thank you, Senator, and thank you to the entire committee for welcoming GLAD today. And we appreciate everybody's testimony, as well as the testimony of Dr. Landry and AFFM. After the hearing on the 17th, we had the opportunity to speak with a representative of AFFM, which is the nonprofit organization that the department has contracted out to provide a kinship navigator program, just to hear their concerns, hear how the program is working generally. And based on that information, and we've provided a summary of that in our material, we would be comfortable in exploring an amendment that would codify the existing relationship with nonprofit organizations. It's very similar to the memo that was the bill that was passed out of committee in the 128th legislature. Really what we're looking for is, and I think the intent is the same across HHS, AFFM, and GLAD, to improve access to resources for children and family generally. So really codifying this in statute would ensure that some sort of kinship navigator program is on the books and enshrined in law throughout administrations. And the other piece that we would be interested in exploring is expanding access to resources, education, materials generally. The major feedback that we got from AFFM was that the majority of the work that they do is from families that actually are not referred to them through DHHS, and that most of the information comes from word of mouth. So the biggest need generally that they see in the state is coming from just a lack of education, lack of resources, and lack of understanding. So we would hope that a bill would be able to help address that, just to improve the interagency and interorganizational collaboration that's already happening.
Are there any questions, Mr. Lombardi? Thank you for being here. I don't see any. So why don't we go to Dr. Landry to hear his response to some of these concerns.
Good afternoon, and thanks again for having me. I believe you have the answers to a few of the questions that were posed, including the data information that was shared in relation to the prior bill that was discussed this afternoon. Certainly, we are very supportive of the kinship navigator type programs that have been successful across the country, which is why we were pleased to initiate this under this administration using federal funding to support that. Also happy to be able to report that through the KRSA funding, the KRSA Act that was passed in December, the kinship navigator funding was extended by the federal government. And so we have additional time for that program. And using those federal dollars with currently no state match required. Our intent is to continue to contract and use those dollars to contract for the duration of their current RFP contract with AFFM to provide this service. It is important to note, as I believe I mentioned prior in testimony, that contract is up for RFP and will be RFP'd again for any interested parties to submit a response to. We are very, quite pleased with the work of AFFM and believe that there is additional outreach and other efforts that could be made, and are happy to, we welcome those suggestions from others, including from Mr. Lombardi, who I believe, as you heard, has already met with AFFM in regard to some of these pieces. So do want to reiterate that most of the families that AFFM serves, both through this Kinship Navigator grant as well as through their other funding, are not involved directly with the department. So these are informal kinship situations. We recognize the need for those, and that is why we are happy to see AFFM in a position to be able to do both of those functions. We are still not in support of this bill because we do think it's much better to have this effort and these contracts placed outside of the department with a community-based provider. We also believe that having one navigator versus the team of individuals that they have at AFFM, I believe 4 or 5 individuals, is more appropriate and can serve more families in that way. We continue to believe that the process that we've laid out in practice over the last couple of years is increasing the support to kinship families. One final note is, as part of the CRSA Act that was passed in December, it does require all states to ensure that their kinship navigator programs are being evaluated as part of building evidence. I believe, as you may remember, currently under the Family First ACF Clearinghouse, there are no evidence-based approved kinship navigator programs. So the federal government is encouraging all of these programs to go through an evaluation process to build the evidence to help to hopefully at some point move one of these programs to meet the requirements of the clearinghouse. AFFM is currently doing that in partnership with the department and I believe USM to do that evaluation. I'm happy also to announce that we were invited earlier this year, and last week, I believe, we agreed to participate in a multi-site collaboration looking at multiple kinship navigator programs across the country. That effort is being led by Casey Family Programs in partnership with Generations United and the University of Washington. And I think that shows our commitment to continuing to work to build the evidence for these programs and continuing to provide that support.
Thank you, Dr. Landry. So do I understand then that the RFP itself, the RFP process could be adjusted to include, to address some of the concerns that have been surfaced during these hearings?
Certainly, I think we can adjust that. I don't know. I need to look exactly where the RFP process stands. Obviously, if it has already been published, then we would need to amend the RFP. But one way or another, we are happy to work with whoever the current contractor in AFFM or others in order to ensure that there are provisions in the contract that include outreach for some of the populations that we are looking at, as well as data reporting in addition.
Thank you. Are there any other questions, comments related to this before we go to the sponsor? Representative Stover, you've heard some of this, you've heard this discussion, any response, any questions, concerns?
Yes, I want to thank Mr. Lombardi for being here today and being such a great advocate, and also Dr. Landry for reiterating the department's position and updating us on some of the work that they're doing. We know we heard this bill, very similar bill in the 128th, 129th, and now again in the 130th. So I don't want to marginalize the importance or relevance of any of the concerns that have been brought forth, and understand clearly the department does not think that adding just one position would substitute or for the AAFM for contracted positions. And we've had a lot of discussion about that. And we've come to a conclusion that we would like to request a letter from the department to be delivered in January of 2022, rather than following the original intent of this bill to create a position. And in that letter that we would ask the department to meet with and hear the concerns of GLAD and the specific concerns that they've addressed both in their testimony and then in the, I don't know if everyone has seen the subsequent testimony they provided to this work session today, but they had some really great considerations in that letter. And I think those could be something that the department could continue to discuss with them. And then also there is a cross-site evaluation group, as I understand it, and that we recommend that the department look at providing a seat to GLAD on that work group so that they can better inform the concerns about youth that they've put forth and continue to put forth. And also the other testimony that we heard were from other underserved populations, including some grandparents. And we heard clearly from the public that they prefer to have AAFM or an outside provider because they don't feel safe, or there were some concerns expressed about the presence of child protective services in their lives out of fear. And that's completely understandable and respectable. But just ask that other underserved groups like other grandparents perhaps have some mechanism so that their voices can be heard as well. And that whatever work is conducted between now and the end of the calendar year, a letter be provided back to us about the progress that the department has made with GLAD and any other groups. And that with that letter, I would be prepared to make a new motion of ought not to pass on LD 699.
How does that sound to people?
I'll
Any
second
other
that
questions?
motion.
Okay, so the motion would be ought not to pass, with the understanding that as soon as we make that vote, we turn around and ask that a letter be sent to the department with the highlights that you've brought up, Representative Stover.
Yes,
Okay.
Dr. Landry, do you want to respond to any of that?
The only thing that I would point out is the cross-site evaluation that's being led by Casey Family Programs is focusing on the evaluation of kinship programs, not necessarily the programming aspects of that. And so while there will be a team that participates with Casey, University of Washington, and Generations United, the focus is clearly going to be on evaluation. And so that may not be the appropriate place for the discussions around programming, et cetera. So that would be my only friendly suggestion, is that instead of requiring certain people to be on a work group that may not be of interest to them, that we simply reference our work on that in our report back to the committee, as opposed to mandating who sits on that work group.
I didn't use the word mandate. It was just a request to consider.
Thank you.
And other ways or other committees internal to the department or to OCFS, then maybe that might be a better fit.
And we are completely open to that. So thank you for that clarification.
Thank you. I would never mandate who you put on your committees. Thank you.
Okay, so there's a motion on the floor, ought not to pass. It's been seconded. Are there any further questions? So we'll go to Ms. Withy for the vote.
Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci.
Yes.
Senator Baldacci, yes. Representative Perry.
Yes.
Representative Perry, yes. Representative Griffin.
Yes.
Representative Griffin, yes. Representative Connor.
Yes.
Representative Connor, yes. Representative Craven.
Yes.
Representative Craven, yes. Representative Madigan.
Yes.
Representative Madigan, yes. Representative Javner.
Yes.
Representative Javner, yes. Senator Moore.
Yes.
Senator Moore, yes. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes. That's 13 yes.
So Representative Stover, would you like to propose a letter?
Yes, I propose that we send a letter to OCFS, making some recommendations, reflecting the things that we've learned throughout this process regarding kinship.
And you will work with Ms. Dooling to craft that?
I will work with Ms. Dooling to craft that. Thank you.
That sound okay to you, Erin?
Yes, that's fine with me because I had a question about the substance on one of Representative Stover's points.
Okay, and we'll see that back anyway before it goes out, right?
Of course, but we don't do letters and usually until later in session.
Okay. All right. So maybe in the interim, Representative Stover could do a bullet point summary of the key things to include, and we could review that, and so that you'd have that for crafting later.
That would be helpful. Thank you.
Sounds good.
I just committed you to do some extra work, Representative Stover. Thank you.
Thank you.
All right.
Second, don't we?
So there's been a motion to send a letter.
So I know that I'm not the arbiter of Robert's rules,
But we don't need a
but
letter.
at the risk of getting myself in trouble, this isn't a real vote. You like the
Right.
ought not to pass is the real vote, and so you're not required to take a vote on letter. But if that's how you choose to do it, you can do it. But I've never seen that done before.
Okay. How about a show of hands from the committee, sense of the committee in support of a letter to the department? That looks unanimous to me. We'll do it that way.
That works. Thank you, Senator.
That worked. Thank you, Erin, for pointing that out. I just wanted to make sure that we had adequately supported our committee members. Okay. So are there other issues to come before us before we look for volunteers, Erin or Anna, if you've rejoined us? Thank
No,
you,
we
Dr.
haven't.
Landry, for being here before. And Mr. Lombardi, thank you. I look forward to some productive conversations and a good report.
Senator, we have one more work session scheduled this afternoon, which is LD 450 related to bone marrow. This bill we heard about a week ago, and it was tabled so that the department could bring back some information on potential activities and costs relating to distributing information about bone marrow donation.
I didn't get that I didn't see that in the revised. Yes, so
So
now we'll go.
Molly has a memo and is prepared to discuss that with you.
Okay. Do you want to do your analysis first, or do you want to hear from Molly?
Well, I did it the last time, so I
Okay.
don't think I need to do it again.
I think it's Molly's turn. All right.
Yes, hello, good afternoon. Once again, I'm Molly Bogart, Director of Government Relations for the Department of Health and Human Services, and I largely introduced myself to give myself time to pull up this memo. But you asked for a little bit of information at the last work session around how much it would cost to develop a pamphlet and make it available instead of standing up the program that is envisioned in LD 450 as drafted. And so I did get a response from Maine CDC about that. They noted that based on their experience and no formal quote, and not a formal quote, a pamphlet, having a pamphlet developed and offered in print, including mailing out to providers or other interested parties, would be roughly $15,000. The dissemination, as well as the design, mailing and frequent and routine mailing would be included in that. You could also consider having the pamphlet developed for digital download, either in addition to a hard copy or instead. For organizations of interest to print, and Maine CDC could email the applicable providers through Maine Care with that pamphlet to make it available to them. They could also share the document with our cancer partners and ask some of them to host on their sites as well and support the promotion. And we could identify cancer treatment centers across the state and disseminate it to them as well. There were additionally some questions about how Maine CDC makes these materials available currently, and our disease prevention program let me know that we have a comprehensive cancer page, which is linked in that memo, and noted that while that web traffic is low, it is certainly a place where we could host the digital download. And we also host what's called the Maine Prevention Store, which is primarily for tobacco and substance use prevention messaging and materials that we provide. But could be a platform used to host this type of information. In obtaining this information from them, they did want to note for you that the LD 450 references the National Marrow Donor Program, but it sounds as though the American Cancer Society donor education information calls that Be the Match, and formally the National Marrow Donor Program. So wanted to make that note for you. I think it's clear to us what you're referencing, but if you wanted to update that in the bill, that is your prerogative.
Thank you for that. Any comments, questions, thoughts? Yes, Senator Moore.
Thank you, Molly. What I was wondering is there not already a digital pamphlet created, maybe by the foundation itself or by another organization? I hate for us to have to recreate the digital pamphlet.
Sure. If I imagine those materials exist, I'd want to hear from somebody at Be the Match or American Cancer Society, or the program that Representative Craven is working with. You certainly could also direct us to make specifically available on our website materials that already exist, and I imagine that would not have any fiscal.
Thank you. That's what I was thinking, Molly.
Okay, any other questions? I don't see any. Where is Representative Craven? So I can, there you are. So, hello. You've heard some of the questions and discussion. Any comments?
Well, as I was listening to Molly, I'm thinking that was probably with all of her, as she included the pamphlets and the distribution to other organizations and that sort of thing. And I think that was kind of my vision to begin with. The worry is that this is life-saving, as we all know. But a lot of people, the awareness for the simplicity really of joining the bone marrow bank is pretty easy. You just do the DNA thing and send it back. And that I think that with awareness that people would participate a lot more. And over 70% of the matches are really not related, not genetically related, and so that it would, so that would be great. So I'm willing to and would love to have any kind of program or any kind of initiative that would expand the awareness and for physicians to be able to not just, just for PCs or anybody to be able to hand out the program, the pamphlet, so that people would be aware of it.
So you referenced pamphlets, and we've also talked about electronically, especially if there was a downloadable pamphlet, that might be sort of an intermediate path. So quite often, as Representative Perry said, you give people links to something to go get some basic information. And I quickly came across a web link called dosomething.org, and another one like that was previously cited called Be the Match. And there are a number of sites like that. I think Molly identified a range of folks to get something like that too, that would be helpful, including blood donors to take back to their families. People who've obviously stepped up once. Representative Meyer?
Thank you, Mr. Chair. I would agree. I like the idea of a downloadable pamphlet. I think that that gives offices and interested parties the ability to just that, download it and hand it out one at a time, or print a couple and put them into their pamphlet racks. But sending out boxes of pamphlets statewide I'm not sure if that's the best use of resources, and I'm not sure that that really gets at the issue here. I think offices that want to promote a better understanding of this can do so with a downloadable pamphlet or something to put up on the wall.
We might stand a better chance of getting it into more places that way.
Yes, exactly.
And the other thing that was done recently or done in the last session was to get March declared as National Children's Cancer Month. So maybe you could piggyback on something like that, some proclamation from the governor that was mandated in that bill, and have that included as a way to get that out more broadly, because those things get distributed widely too. So I'm hearing some interest in asking the department to come up with some sort of downloadable and readily findable pamphlet and links that would get people the information they needed to increase the likelihood of their becoming a donor. Do I hear any sentiment for something other than that? Is that acceptable to you, Representative Craven?
Yes.
Okay. So I'll entertain a motion then. Yes, Representative Perry, who can't find the button.
The button, right. It must be getting late or something. I move that we do what you said.
What he said.
I second that.
All right. There's been a must be Thursday. We've touched a lot of bills this week, people. We have touched a lot of bills this week. I showed it to a friend of mine the other day who's been around politics and the state house for 30 years. He said, that is an amazing agenda for a week. So anyway, we have a motion on the floor and a second. I think the motion was what he said, but I specifically referred to encouraging the department to develop a downloadable pamphlet and create links that would get the message out about how important this service is to communities. And it was seconded. Yes, Aaron?
I'm sorry, you used the word encourage. Are you directing the department to
Yes.
amend their adjust their website to post?
They always
these
do
links?
what we want anyway. So yes, that was direct.
Okay, sorry.
Representative Madigan.
I just want to say, I think the motion is ought to pass as amended.
Okay, we'll make it ought to pass as amended. It's been seconded. All right. I see no further discussion. Thank you for that clarification. So now we'll turn to Ms. Withy.
Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci.
Yes.
Senator Baldacci, yes. Representative Perry.
Yes.
Representative Perry, yes. Representative Griffin.
Yes.
Representative Griffin, yes. Representative Connor.
Yes.
Representative Connor, yes. Representative Craven.
Yes.
Representative Craven, yes. Representative Madigan.
Yes.
Representative Madigan, yes. Representative Javner.
Yes.
Representative Javner, yes. Senator Moore.
Yes.
Senator Moore, yes. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes. That's 13 yes.
Okay, so now that we've taken care of the LDs that are on the list, are there any other agenda items? And we'll go now to Erin and Anna if she's rejoined us.
Just reports.
Anything else? Anybody want to volunteer to do a report? I don't see any volunteers. Is there anything else we need to touch base with? And I'll include Ms. Withy in that question. Nope. Okay. So that gets us to the calendar and our next meeting being on Monday in the afternoon, the 29th.
Monday at 1.
At 1, yes. Monday at 1. Okay.
And then our sessions on Tuesday and Thursday were canceled, our committee meetings, or they've been rescheduled, but we do have meetings Thursday and Friday next week.
So we have a Friday morning meeting next week.
Yes.
Okay.
So Tuesday and Wednesday were canceled,
Yes.
and we're meeting Thursday and Friday.
Yes.
Yes.
Okay. Thank you all. It's been a productive week. A lot of good work. All right.
Have a nice night, everyone.
Take care.